Okay, good afternoon. So today we will be starting with the next topic of GIT. So for GIT, as far as medicine is concerned, medicine subject is concerned, we can broadly divide it into two parts. One will be the liver part, and second will be the intestinal part. So in the liver part, let's make a overview ki how will we discuss this topic of liver in the GIT. In the liver part, we first will discuss the disorders of serum bilirubin metabolism. Then we will be doing acute viral hepatitis, then chronic hepatitis or cirrhosis, and then we will do the complications of cirrhosis. Complications of cirrhosis. So let's start with the disorders of bilirubin metabolism. Disorders of bilirubin metabolism. So to understand this disorder, let's see first what is the metabolism cycle of bilirubin. So bilirubin is synthesized from, this is a cycle of bilirubin is mainly made from the degradation of heme. So heme is the major protein which form bilirubin, but minutely it can be from myoglobin, then it can be from cytochromes. So but the major remains the heme which synthesize bilirubin, and this bilirubin is unconjugated variety. Unconjugated means ki it is water insoluble, and this part of bilirubin is never excreted in the urine. So this unconjugated bilirubin, there is a uptake in the liver, and in the liver it undergoes a process of conjugation. This is the liver. So here unconjugated bilirubin is converted into a conjugated fraction, conjugated bilirubin, and this conjugated bilirubin is then excreted with the help of a protein which is known as MRP2 protein. So this protein excrete conjugated bilirubin into the, ultimately into the GIT. So this bilirubin conjugated fraction with the help of MRP2 is excreted in the GIT, conjugated bilirubin. And in the GIT, this conjugated fraction with the help of gut bacteria, is converted into urobilinogen, which is then excreted through the urine, and some component of this conjugated bilirubin can also be excreted in the stool in the form of stercobilinogen, and that is in the stools. And some portion of bilirubin is reabsorbed through ileum and then goes again to the liver, hepatic circulation, enterohepatic circulation. So this is what happens to the bilirubin. And let's see from this diagram what will be the disorders of say those which are causing elevation, predominant elevation of unconjugated bilirubin. So disorders of bilirubin is divided into two groups, where there is a predominant elevation of unconjugated, and second is when there is a predominant elevation of conjugated bilirubin, and that will be isolated elevation. Isolated means liver enzymes are normal, liver enzymes are not elevated. So starting with the first, what could be the disorder? First we'll understand from this diagram flow chart what will be the disorder of unconjugated high bilirubin. So either it could be a increased synthesis, or it can be a decreased uptake at this step, or it can be at this step that unconjugated is not converted into conjugated fraction. So once it enter into the liver, if it is not able to convert into conjugated fraction, it can back leak into the plasma if there is no conversion. So it can back leak and can cause elevation. So here at this step, the enzyme implicated for the conversion is UGT, is the UGT enzyme, UDP glucouranosyl transferase, UGT enzyme. So starting with the steps of unconjugated high bilirubin, let's see. So first we'll talk about the disorder in which there is isolated elevation of unconjugated bilirubin. Isolated elevation. So first step was the increased synthesis. Increased synthesis of the bilirubin, which is an unconjugated fraction. So increased synthesis can be because it is synthesized mainly from heme. So if there is a accelerated degradation of heme, which is a protein of hemoglobin, it will cause increased synthesis. So that accelerated degradation occur in hemolytic anemias. Increased synthesis, hemolytic anemia. And by definition, we all know hemolytic anemia is increased RBC destruction, premature increase RBC destruction, premature destruction, and in periphery, in the peripheral blood. Peripheral means outside bone marrow. Outside bone marrow, there is an increased RBC destruction prematurely. And we all know the examples of hemolytic anemias. There are so many examples. It include like hereditary spherocytosis, like G6PD deficiency, and autoimmune hemolytic anemias. So there are so many causes. Now second is similar to hemolytic anemia, it is ineffective erythropoiesis. Ineffective erythropoiesis. So ineffective erythropoiesis is similar to hemolytic anemia, but there is a difference. Difference is so ineffective erythropoiesis is increased RBC destruction, and it is also premature, but it is in bone marrow, in the bone marrow, ineffective erythropoiesis. And the characteristic examples are usually asked for ineffective erythropoiesis, and that common conditions are megaloblastic anemia, megaloblastic anemia. It includes thalassemias. It include severe iron deficiency. Severe iron deficiency. It also include some congenital disorders like congenital dyserythropoietic anemias. Congenital dyserythropoietic anemia. So important is it is asked megaloblastic anemia, that it causes jaundice or icterus, and there this icterus is because of unconjugated high bilirubin, unconjugated high bilirubin. Then third is the large hematoma, large hematomas, where there is a destruction of continuously RBCs from this side. Also, uncommon cause but possible of high unconjugated is lobar pneumonia. Lobar pneumonia. In lobar pneumonia, there is so much of RBC exudation in complete lobe that they are destroyed and they cause unconjugated high bilirubin. Unconjugated high bilirubin. Now, coming to the second step of high bilirubin, that is a decrease uptake. Decrease in uptake. So decrease in uptake can be because of congenital causes, and congenital causes include Gilbert syndrome, remember this is also a cause of decreased in UGT activity also, but second mechanism is a decrease in uptake. While acquired causes usually include of decreased uptake are the drugs. So these drugs are common drugs commonly implicated: rifampicin and ribavirin, as well as probenecid. So there is a decrease in uptake because of these drugs, and very important pharmacological also, the side effect of these drugs is a decrease in intake. Now coming to the third step where unconjugated bilirubin can be high, and it is a decrease in UGT activity. Decrease in UGT activity. So this decrease in UGT activity can be again also congenital cause and acquired cause. So first let's see what are the congenital causes of decreased UGT. So there are three causes of congenital decreased UGT activity. First is Crigler Nazar type 1, second is Crigler Nazar type 2, and third is Gilbert syndrome. Gilbert's syndrome. So these are the three congenital causes where there is a decrease in UGT activity. So to differentiate these three, let's see what the points that we can see. First is the UGT activity. First is the UGT activity. So in Crigler-Nazar type 2, UGT activity is almost zero. There is no UGT levels. Crigler-Nazar 2, the UGT activity is 10%, and Gilbert syndrome, it is 33%. It is 33% UGT activity. Now, about the mode of inheritance. Crigler-Nazar 1 is autosomal recessive, 2 is autosomal recessive again, but Gilbert syndrome is both autosomal recessive as well as autosomal dominant. Autosomal dominant. Then the level of serum bilirubin, and this is a total serum bilirubin. In 1, it is a very high level, usually more than 20. More than 20. Of course, standard units milligram per deciliter. Milligram per deciliter. Then in 2, the bilirubin levels ranges from 6 to 20. 6 to 20. While in Gilbert syndrome, the level are usually less than 6. Usually less than 6. So, clinically, if we'll see whether kernicterus will be seen or not. So, kernicterus is the deposit of bilirubin in the basal ganglia most likely, and this occur when the total bilirubin is 20 or more than 20. So, the risk is it is present in 1 because 6 to 20, so the risk will be uncommon risk. So, kernicterus is rare in 2, while it is totally absent in cases of Gilbert's syndrome. Gilbert's syndrome. And when we look at the mortality rate of these syndromes, so the mortality in cases of 1 is less than 1 year. And this mortality is without treatment. Without treatment. While Crigler-Nazar 2 usually survive till adulthood, and in Gilbert syndrome there is no increase in the mortality. Coming to the investigations, and main investigation will be the liver biopsy for these 3 disorders. So if we do a liver biopsy, remember Crigler-Nazar 1 enzymatic defect shows a normal pattern of biopsy. 2 will also show a normal pattern of biopsy, liver biopsy, but Gilbert syndrome, here due to unknown mechanism, what happens, there is some deposit of a pigment which causes a blackish discoloration, and this pigment is a lipofuscin pigment, and which gives a black pigmentation to the liver, black color to the liver. Now, and regarding the treatment aspect, so if we'll give the medicine, say response to phenobarbital, we all know that phenobarbital is enzyme inducer. So, the response is complete response in Gilbert syndrome, a complete response, 100% response, while in 2 there is a 25% response, 25% response, while phenobarbital has no response in Crigler-Nazar 1 because the activity is 0%. Activity is 0%. So, then what should we do for the treatment in Crigler-Nazar 1? That will do a liver transplant. Liver transplant. So, this liver transplant is done in cases of 1, and that will be the treatment of choice. That will be the treatment of choice in Crigler-Nazar 1 because there is no option, there is no response to the medical therapy. Now, Coming to the curricular Nazar 2, liver transplant we can do, may be done, uh, but usually these patients do respond with phenobarbital, and liver transplant is not required at all in cases of Gilbert syndrome. In cases of Gilbert's syndrome. So these are the syndromes of congenital syndromes. Then coming to the second group of decrease in UGT. So this is acquired cause. So in the acquired cause, we'll say drugs, and again important pharma caution, drugs which inhibit UGT activity. So we know the drugs which enhance UGT activity was phenobarbital. So there are some drugs which inhibit the activity of UGT, and these drugs will include inhibiting the activity are gentamicin and chloramphenicol. While there is one more syndrome which is breast milk jaundice. So what happens in this disorder, that fatty acids in the breast milk, they inhibit the UGT of neonate, and these fatty acids are present in the maternal breast milk, so they inhibit the UGT of the neonate. And remember, this is a benign condition, and it will automatically recover on its own as the neonate will start building UGT of own. So this is breast milk jaundice. So these are the causes where there is a elevation of unconjugated bilirubin. And remember, in all these causes, urinary bilirubin will be absent. Because it is unconjugated type. So let's see what are the causes of isolated. Second group of disorder of serum bilirubin is isolated elevation of conjugated bilirubin. Isolated elevation of conjugated bilirubin. So this is defined as when the conjugated fraction is more than 15% of total bilirubin. So this is a specific definition. Isolated elevation of conjugated bilirubin. And remember, isolated again focusing that liver enzymes are normal. Liver enzymes are not elevated. So what are the disorders? So these disorder we have to just look into the after conjugation what was happening. So just for a revision, this is the liver, and there was a conjugated process with the help of UGT. Unconjugated was converted into a conjugated fraction, into a conjugated bilirubin with the help of UGT. And this conjugation process was taking place inside the endoplasmic reticulum. Now, from endoplasmic reticulum, this conjugated bilirubin is transported. So there is a transportation. transportation to the excretory protein, and that is a MRP2 protein, which causes excretion of bilirubin into the bile system, and hence into the GIT. So there are only two defects which can happen. One could be because of the transport defect is not working. So conjugated bilirubin is not transported to its respective MRP2. So what will happen? This conjugated bilirubin will then go into the plasma, or second defect could be a MRP2 mutation, that this is not working, so it is not able to excrete bilirubin, and this bilirubin then leak into the plasma. So these are the two steps which can be defective: a transportation defect or a excretory defect by MRP2. So these two disorder we can define as Dubin-Johnson syndrome, Dubin-Johnson syndrome, and second is the Rotor syndrome. Second is the Rotor syndrome. So the cause of Dubin-Johnson syndrome is this mutation of MRP2, that means the excretory defect. So cause is inhibitory mutation of MRP2 protein. So there is a no excretion, while Rotor syndrome is a transport defect. So let's first compare these two disorder, and in the same sequence that we have done the congenital disorder of UGT. So mode of inheritance, both they are autosomal recessive. Then after mode of inheritance was the level of serum bilirubin. Usually the total bilirubin here is mildly elevated, and on an average it is less than 4. Sometime it can be elevated also, more than 4, but that is during the time of prolonged fasting. So it can be increased after prolonged fasting. In both the conditions. Then kernicterus is absent in both, because kernicterus occur when the bilirubin is 20. So here the level of 20 is not seen. Now coming to the mortality rate of these two conditions. Mortality in both the condition, it is not increased. So the life expectancy of these two syndromes is normal. Now coming to the investigations, and first we have seen was the liver biopsy. So let's see what happens here. Dubin-Johnson syndrome and Rotus. So liver biopsy in cases of Dubin-Johnson syndrome will show us a black pigmentation. And this is due to accumulation of epinephrine metabolites uh, which are excreted through these epinephrine metabolites are excreted through MRP2. So there will be accumulation of epinephrine metabolites as they fail to excrete through MRP2 because their method of excretion is MRP2. So if that is not working, they will not be excreted from the liver, deposited in the liver. And we all know that epinephrine is a catecholamine and the color of catecholamine is black. So in Rotor syndrome, liver biopsy is absolutely normal. Liver biopsy will be normal in Rotor syndrome. Now, there is one more test which is important and can differentiate these two conditions. And that investigational test is known as a BSP test. BSP test. So BSP test is Brome sulfilin test. Brome sulfilin test. So first let's see how this test is performed and what are the normal values expected in this Brome sulfilin test. So BSP is given as IV. So we give a fixed amount of BSP and that is taken up by the liver. So this BSP is metabolizing into the liver, and this follows almost the same pathway that it is excreted through MRP2. It is excreted through MRP2, IV BSP. So excreted into the GIT. So when we give IV BSP, liver will take up the IV BSP and then it is excreted through MRP2 into the GIT. So after some time, the blood level of BSP will be zero because from there it has excreted into the GIT. So the normal value of BSP, normal value is that there is a clearance after 90 minutes. There is a clearance of BSP after 90 minutes of IV. So what is the basic pathology of Duven-Johnson is the MRP2 defect. So IV BSP will not be able to excrete. So this BSP then moves back into the plasma. So its level will not decrease. So in Duven-Johnson syndrome, there is no clearance of BSP because it back diffuse again into the plasma. Failure of MRP2. But what happens in cases of Rotor syndrome, that this BSP will go into the liver. There is a uptake into the liver. And remember here MRP2 is absolutely normal. MRP2 is functioning normally. But the defect here is the transport defect. So the BSP is not being able to transport through a same pathway to MRP2. So it will then try to back diffuse into the blood. But what happens that when it is back diffusing, some portion directly can go to the MRP2, some portion. Suppose we are giving 100 units of BSP, it is entering in the liver, and from here 50 50 units are back diffused into the plasma and 50 are directly captured by MRP2. So these 50 molecules will be excreted. Now this 50 again will enter in the liver, and follow the same route. So out of 50, 25 will again come back and 25 will be excreted. So the excretion of BSP is possible, but it will be a delayed excretion. So the response in rotors about BSP is a delayed clearance. It will clear, but will take, say, maybe 180 minutes for disappearance. While in Dubin Johnson there will be a absolutely no clearance. Now coming to the treatment part, actually mortality is not increased in both the disorder, so treatment is not required in these disorder because they are not causing any mortality or morbidity. So treatment not required in Dubin Johnson or Reuters syndrome. And one more point is the urine bilirubin. So these two syndrome are causes of conjugated high bilirubin, which will be in the urine. So if urine dipstick is positive for bilirubin and patient has jaundice, he will be having a conjugated hyperbilirubinemia. So these are the important disorders of bilirubin. Now moving on to the next topic, and a very important topic of liver, and that is acute viral hepatitis. So we'll study these hepatitis in a sequence, and first cause of acute viral hepatitis is hepatitis A. So let's see what are the mode of transmission of hepatitis A. We all know the primary mode is, the main mode is fecal-oral, is the primary mode of transmission. But remember, it can also be transmitted by blood. Blood, though, is a rare mode of transmission, but possible. Reason being that there is a transient viremia during late incubation period. So liver biopsy of rotors is normal, that we have discussed in Dubin Johnson. It is a black pigmentation. Rotors is a normal finding. So transient viremia. Viremia means ki the virus is in the blood. So that can be transmitted during late incubation period. Now unique clinical features of hepatitis A, acute hepatitis A. We will not do the non-specific ones like prodrome phase, icterus, jaundice, nausea, that occur in all type of acute viral hepatitis. So let's see what are the unique clinical features. First, we'll always do a most common thing associated with that particular virus. So this is the most common cause of acute viral hepatitis in children. Remember, acute viral hepatitis in children is hepatitis A, while the most common presentation most common presentation is anictic hepatitis. Anictic hepatitis. Most common presentation in children. And this has the MCQ which has come, previous MCQ. That means ki the patient is usually asymptomatic. Jaundice will not be the complaint. It is only anictic hepatitis. Without jaundice, there will be a hepatitis. Liver enzyme will be elevated. So acquired causes of decreased UGT. Acquired causes of decreased UGT is the drugs, and drugs include chloramphenicol and gentamicin. While second was breast milk jaundice, where fatty acids in breast milk, they inhibit the UGT of the neonate. Fatty acids in the breast milk, they inhibit the UGT of the neonate. Now, third is that in adults, acute hepatitis A is a uncommon infection. It is uncommon, but it causes, if it occur, it causes a severe disease. Disease is severe. Now, fourth, it has come 2 years back in the AIMS question, and that is a relapsing hepatitis. Relapsing hepatitis. So, relapsing hepatitis is a specific term. Relapsing hepatitis is in relation to acute viral hepatitis, and that is because of hepatitis A. So let's understand what does relapse means, and for this let's make a graph, or this is a graph, a time in months, and clinical disease on the y-axis. Clinical disease like nausea, vomiting, abdominal pain. So here is the 0 month, 1 month, 2, 3 months. So in most of the cases, when hepatitis A infect the body, there is gradual increase in the symptoms. Plateau phase occur, followed by a decline. So this is a monophasic disease. Which usually occur in hepatitis A infection. But some strain or some species of hepatitis A, what they do, they cause a very fast clinical disease, a plateau, and a rapid decline of clinical symptoms. But it remains in the body, it remains silent in the liver without causing any symptom or clinical disease. And again, before leaving the body, it again causes a second phase of clinical disease, and then declining phase. So this second phase is known as a relapsing hepatitis. It is by the, remember this very important point, it is by the same virus which has caused the previous disease. So virus was silent in the liver without causing any clinical symptoms, and when body it has to leave the body, how does it leave the body? By the immune system of the patient. So it will again cause a clinical disease, and this second phase might be a decrease in intensity than the first phase, might be a milder form of disease than the first phase. So this relapsing hepatitis is seen only and only in hepatitis A. Hepatitis A. Now, coming to the third important feature which is being asked usually is the serology. Serology of hepatitis A. Serology of hepatitis A. So, in hepatitis A, we get IgM anti HAV. IgM anti-HAV. So, what does it represent? It will represent acute hepatitis A infection. Acute hepatitis A infection. Then IgG anti-HAV will also be seen. Yes, it is a possibility, but let's understand what does IgG represent. Let's say for any hepatitis virus. So we'll make a possibilities ki what is the significance of IgG. So IgG first can represent a chronic infection. Second possibility of IgG, yes, it can be a remote recovered infection, that it occurred say 6 months back, now has recovered, totally recovered, and these IgG are the antibodies which will remain there in the blood, Then third possibility is it could be a post vaccination also. Post vaccination. So IgG, these are the three possibilities. Let's rule out what will not be possible in hepatitis A. So IgG anti-HAV chronic infection in hepatitis A is not seen. So it is ruled out. This possibility is ruled out. Now, remote recovered infection, yes, true, it can be a possibility. Will there be any vaccination? Is there any vaccination for hepatitis A? Yes, there is a vaccination. So, this IgG anti-HAV can represent post-vaccination status also. So, this is also true. So, common feature between these two possibility is the feature that patient is immune. Patient is immune to reinfection. Patient is immune to reinfection, and we all know through our knowledge of immunology that immunity can come from two sources. First, it can be a natural immunity. Natural immunity means the infection has occurred and which has provided the long lasting immunity. So that we call it as a remote recovered infection. Remote recovered infection is a natural immunity, while immunity through vaccination is an artificial immunity. Artificial immunity. So the common thing will be the patient is immune. This is a safe antibody for hepatitis A patient. Hepatitis A patient. Now, the complications and treatment we'll do as a common after we finish all the acute viral hepatitis. So coming to the second viral hepatitis, and that is hepatitis B. Hepatitis B. So let's do what are the mode of transmission. Mode of transmission. So the mode of transmission are percutaneous, Percutaneous means two important modes can be through needle stick injury, or it can be through a blood transfusion. Through blood transfusion. So now let's see what are the risk of needle stick injury for hepatitis B patient. So the risk here is 6 to 30% needle stick injury. While blood transfusion, the risk is 1 in 2 lakhs of blood units transfused. 1 in 2 lakhs of blood units transfused. That means suppose if a hospital is transmitting 2 lakhs is having not transmitting is having 2 lakhs of blood transfusions each year, so one patient will get hepatitis B. And remember, this figure, though it seems a very low figure, 1 in 2 lakhs, but this is a high value because this blood units are the screened blood. That despite screening for hepatitis B, there is a transmission. There is a transmission despite screening. So this is an apparently we can say uninfected blood. Apparently uninfected blood. Still, the risk is 1 in 2 lakhs of blood transfusions. Now, the second mode is the vertical mode of transmission. Vertical from mother to child. So let's see what is the risk. Risk will be dependent on the mother. If mother is HBe antigen positive, if mother is HBe antigen positive, the risk of transmission to the neonate is very high, 90%. Risk is 90%, while if mother is anti HBe positive, so this is a protective antibody, it has neutralized the antigen and the risk is dropped to as low as 10%. So this is the importance of these anti-HBe. So there are some questions on the vertical transmission. So first is, this is the most important mode of transmission, especially in developing countries and those countries where it is endemic. So this is the most important mode of transmission, especially if we talk about India. Second, the time period where maximum transmission occur. So time period of pregnancy when maximum transmission occur, it is during delivery. Then what is the risk by breastfeeding? So breastfeeding feeding transmission. Remember, it is not transmitted by breastfeeding. So answer is no. It is not transmitted by breastfeeding. Then the risk of chronicity. Risk of chronicity. In the neonate, the risk is very high, 90%. 90%. So this is a very important mode because child will be affected with hepatitis B lifelong. So this is the vertical mode of transmission, while for hepatitis B part from this center, hepatitis B we have just done the mode of transmission, and mode of transmission we have done the percutaneous mode first. Percutaneous mode is a needle stick injury where the transmission risk is 6 to 30%. So percutaneous needle stick injury risk is 6 to 30%, while in second is blood transfusion. In percutaneous blood transfusion, so the risk is 1 in 2 lakhs of blood units transfused. 1 in 2 lakhs of blood units transfused, and that blood is a screened blood. That is a screened blood. Now the third mode of transmission is a highly variable mode of transmission, and that is sexual mode of transmission, where exact percentages are not known. It is a variable mode of transmission. Variable mode. Now coming to the unique clinical features of hepatitis B. So let's start with most common. Most common thing associated with hepatitis B. So hepatitis B is the most common viral cause of carrier state, and hepatocellular carcinoma, SCC. Most common viral cause of a carrier state as well as a hepatocellular carcinoma. So why hepatocellular carcinoma, though the cirrhosis is the most common viral causing cirrhosis is hepatitis C, but that is not the most common viral cause of carcinoma. It is hepatitis B, which is the most common viral cause of hepatocellular carcinoma. So there are two reasons for it. First is chronic hepatitis B can directly convert into hepatocellular carcinoma. Can, without cirrhosis stage, without the cirrhosis. So it is not mandatory that patient should undergo cirrhosis and then develop carcinoma in chronic hepatitis B. So direct conversion, that means it is a rapid progression. Also hepatitis B has got one antigen which predispose it to carcinoma, and that is HBx antigen, and this increases the chances of carcinoma. It is a carcinoma marker. While for chronic hepatitis C, first patient should have cirrhosis, and then patient will develop hepatocellular carcinoma. So this will be a slow process over a period of say 3 decades. Slow process over a period of 3 decades. Therefore, the chances is hepatitis B is more associated with carcinoma than hepatitis C. And sometime what happens then, when chronic hepatitis C is converted into cirrhosis, so the patient will die from cirrhosis before developing a carcinoma. So complications of cirrhosis, patient will die rather than developing the carcinoma. Now, the second important clinical feature for hepatitis B is this is not seen in other acute viral hepatitis, and that is a serum sickness like illness. Serum sickness like illness, and in this this is a very important clinical feature, might be given in the questions, that serum sickness like illness, patient present with rash, high grade fever, and arthralgias. So this will be associated with acute hepatitis B. And we all know that serum sickness like illness is a type of type 3 hypersensitivity. Type 3 hypersensitivity. Now, third is old MCQ, but important MCQ, and that is what is the mechanism of liver injury in hepatitis B? So the mechanism of liver injury, it is because of a sensitized T lymphocytes, and these T lymphocytes are sensitized by the virus. So these T lymphocyte then causes the damage. So sensitized T lymphocyte. Also, this is more than the direct cytopathic viral effect. More than a direct cytopathic viral effect. So if question comes ki mechanism of liver injury, answer will be, if they are given separately in the option, then your preference will be sensitized T lymphocytes. But if option is sensitized T lymphocyte plus direct cytopathic effect, that will be the best choice. Now, again from pathology, but question come is the this immune complex. So immune complex contain which antigen? So remember, immune complex contain HBs antigen more than HBe antigen. So obviously the preference should be HBs antigen. So immune complex lesions, and these immune complex lesions can also affect the kidneys, causing glomerulonephritis. So that immune complex glomerulonephritis will contain HBs antigen. So you should be specific in the topic, because it will be difficult to know what were the last 2 minutes. So like if you have missed the unique clinical feature, then we can revise it quickly, but as typing the last 2 minutes will be difficult for me to where should I revise from. Okay, so let's assume that you have missed the unique clinical features. So these are the unique clinical features of hepatitis B. First unique clinical feature was it is the most common viral cause of carrier state and carcinoma and hepatocellular carcinoma. Second, it causes serum sickness like illness by causing a type 3 hypersensitivity, which is an immune complex hypersensitivity. And how to recognize this clinically? Patient will have rash, will have high grade fever, and will have arthralgias, joint pains, along with hepatitis. So these clues goes in favor of serum sickness like illness, and hence hepatitis b. Now the mechanism of liver injury by hepatitis B is sensitization of T lymphocytes by the virus. So sensitized T lymphocyte causes liver injury more than the direct viral effect, direct cytopathic viral effect. Now immune complex contain, this is also a question, कि immune complex of hepatitis B contain HBs antigen more than HBe antigen. Now the fifth important unique clinical feature of hepatitis B is it is associated with some unrelated diseases. Unrelated means कि those disease do not have the same mode of transmission as hepatitis B. So it is associated with leprosy. This question has already come. It is associated with polyarthritis nodosa. Or this is also MCQ which has come. Polyarthritis nodosa is associated with hepatitis B. Then it is associated with Down syndrome, and it is associated with Hodgkin's lymphoma. Hodgkin's lymphoma. So these are the 4 unrelated diseases. Related disease will be HIV because the mode of transmission of B and HIV is same. Now coming to the serology. Serology of hepatitis B infection. So this is very very important, this serology, and many questions come from this serology. So we'll go step by step. So let's see the first set of questions which are asked, and first set of question comes from the say a time sequence key when this which serological marker is elevated first, followed by which marker, followed by which marker. So time sequence of these marker, this will be our first in the serology, time sequence. So this will understand with the help of a diagram or a graph. This will make a time diagram. This is the time period, and we'll take it in weeks. So this is the y-axis will show the titers of serological markers. So this is the time period. We'll say it as 0 week. 0 week means कि there is a inoculation of the virus at 0 week, and this will take as a symptom here. Though hepatitis B symptoms are variable, but for single point value, just to understand the things, we'll take the symptom as a mean time of 12 weeks. So this is 12 weeks, though it can range. Plus minus 4 weeks here and there. So this period from inoculation to symptoms we all know is a incubation period. So this is incubation period. So During incubation period, the viral marker which is elevated is this marker. It is elevated, and this just to understand, we'll take it as say 4 to 6 weeks before symptoms. 4 to 6 weeks before symptoms. Say we'll take it as 8 weeks. 8 weeks. So this marker which is detectable even in the incubation period is HBS antigen. This is HBS antigen, and this is elevated, and we are talking about the graph of acute viral hepatitis, acute hepatitis B. So if it is a acute hepatitis B, HBS antigen should fall before 24 weeks. So let's assume that this is 24 weeks. It never extend beyond 24 weeks. If it is extending beyond 24 weeks, HBS antigen, it will be a chronic hepatitis. It will be a chronic hepatitis B infection. Chronic hepatitis B infection. Now, we all know that whenever there is some antigen in the blood, there is development of its antibody. Development of its antibody. So, after HBS antigen, immune system will start making the antibodies. But remember, these antibodies are so low in titers that they are not detectable. Remember, they are not detectable during early part, but they are made in the body. They are made in the body. So let's assume these antibodies. So these will be the antibody. After few weeks of HBS antigen, they are produced in the body. The level start increasing like this, and this is the detection threshold. And when they reach the detection threshold, they will be present in the laboratory test. Present in the laboratory test. So HBS antigen, after few weeks, its antibody is made by the immune system, but it is at such low titers that conventional laboratory test will not detect this antibody. This antibody start building up, levels start increasing, and when they reach a detectable threshold, then we can say yes, this antibody which is anti-HBS will be detectable. So there will be a time period when HBS antigen disappear, and before the appearance of its antibody. So this period where there is no HBS antigen and no anti-HBS antibody, this is known as a window period. This is known as a window period. And remember, why HBS and anti-HBS antibody is not detectable? It is not made. It is because the titers are so low that it is undetectable by lab test. But now we have more sensitive test which has come. So in most of the center, this window period is narrowed down, and maybe in some centers it is so sensitive that this window period does not occur also with the latest more sensitive test. Now second marker which is elevated after HBS antigen, maybe after a couple of weeks, here is the elevation, and this elevation is HBE HBE antigen. This is HBE antigen. After a couple of weeks of HBS antigen. HBS antigen. Then third marker at the symptom onset or just after symptoms is this marker, and this marker is anti-HBC. Anti-HBC. So the duration of window period, it ranges from 0 to 4 weeks. 0 to 4 weeks window period. 0 when there are sensitive techniques available with us. So we are talking about the acute one. So this anti-HBC will be of IgM type. Will be of IgM type. Now, on the basis of this graph, let's see some questions. Let's see some questions which are important ones. So this is depending on the time sequence of hepatitis B infection. So if question is earliest marker to be elevated in a case of acute hepatitis B. In a case of acute hepatitis B, answer will be HBS antigen. HBS antigen. But if question comes, read the language of the question very carefully. If question comes reliable marker of acute hepatitis B, remember reliable. HBS antigen can be seen in chronic hepatitis B also. So the reliable marker will become IgM anti-HBC. Anti-HBC. Then incubation period marker. Marker during incubation period. So from this diagram, we can see that before the onset of symptom, two markers can be elevated in the body, HBS antigen and HBE antigen. But if we have to choose a single best response, so answer will be HBS antigen. It is the single best. Reason being, look, the symptom can be variable. Suppose if symptoms comes early, so HBS antigen will come at the symptom and HBS antigen will be at the incubation period. So this is a variable. This is variable. Also, one important reason why we have not taken HBE antigen as the marker, incubation period marker, is pre-core mutant. Pre-core mutant fails to synthesize HBE antigen. So pre-core mutant are some strain of hepatitis B which are HBE antigen negative. So the best will be HBS antigen. So we'll see this pre-core mutant also in a few minutes. Now, if question comes, so let's see from this table. Question come marker during window period. Answer will be this red line. Anti-HBC will be the marker which will be present during the window period. Then not HBE antigen. Reason same, because of pre-core mutant which are HBE antigen negative. So antibody will be in almost 100% cases, but HBE antigen will not be in 100% cases. So window period marker is anti-HBC IgM type. Window period marker, anti-HBC IgM type. Now, uh, let's see the second set of question which are important for the serology is the significance of different serological marker. Significance. So, significance is let's do one by one. If we'll say the most important diagnostically marker, most important diagnostic marker is, remember, anti HBC antibody. Most important diagnostic marker. So HB anti HBC antibody can be of two types, IgM and IgG. IgM and IgG, anti-HBC. So when it is IgM type, our diagnosis will be it is a case of acute hepatitis B. Acute hepatitis B. While if it is IgG type, so what are the possibilities? Possibilities are that it can be a chronic infection, chronic hepatitis B infection, or it can be a remote recovered infection. So this we have done in hepatitis A also, the significance of IgG antibody. So anti-HBC IgG can represent either it can be a chronic infection, or second possibility is it could be a remote recovered infection. And why we have not take the vaccination, post vaccination? Because in vaccination we give surface antigen, a subunit of surface antigen. So the antibody in post vaccination will be anti-HBS, not C. So that possibility is ruled out post vaccination. So we are left with chronic hepatitis B and remote recovered infection. And when will we say that it is a chronic hepatitis B? In presence of IgG anti-HBC is when there is HBS antigen positive. If this antigen is simultaneously positive with IgG of anti-HBC, that means it is a chronic hepatitis B, because in body HBS antigen is present for more than 24 weeks. IgG usually more than 24 weeks. So this will represent it is a chronic hepatitis B. Now, when will we say that it is a remote recovered infection? Remote recovered means body has taken care of antigen, HBS antigen. It has removed it from the body by the immune system. And which marker or serology is removing HBS antigen? It is a anti-HBS antibody. So if this antibody is present along with IgG of anti-HBC, it means the patient is remote recovered. So isolated, we can't make a diagnosis on the basis of IgG. We can make only possibility that it can be a chronic one or it can be a remote one. So to make accurate diagnosis of chronic hepatitis B, antigen should be there along with this antibody, and if it is to be a remote recovered, anti-HBS should be there. So this is the first serological marker and its importance. This is the most diagnostically important antibody. Now second antibody is take this antibody anti-HBS. To remember the significance of anti-HBs, remember one word, it is a immune. Patient is immune. So we all know that immunity can come from a natural infection, or it can be artificial. It can be artificial. So natural will say that it is a remote recovered infection. Remote recovered. And to say a remote recovered infection in presence of anti-HBs, there should be some evidence of natural infection, and that is IgG anti-HBC should be positive. IgG anti-HBC should be positive. Should be positive. Now, artificial. Artificial means it is a post-vaccination. Post-vaccination. So, this will say when IgG anti-HBC is negative. When this become negative, because it is only HBs surface antigen, and that too subunit was given. So there is no question ki why should HBC elevate. It is only anti-HBs which will be elevated. Now the third antibody is anti-HBe. So to remember its significance, it means patient is having low infectivity. Low infectivity, anti-HBe in most of the cases. There can be some exception which we'll do just now. So most of the cases anti-HBe means low infectivity. Low infectivity. Now HBs antigen. Coming to the antigen significance, we have done 3 antibodies. Now coming to the antigens. HBs antigen means that there is a viremia. Virus is circulating in the blood. Virus is circulating in the blood, and this can be positive in. Remember, this can be positive in acute hepatitis. Can be positive in chronic hepatitis, can be positive in cirrhosis, can be positive in carrier state. So HBs antigen will not isolated, will not make a diagnosis. It can be seen in any phase of hepatitis B. Any phase of hepatitis B. It just represent a virus in the blood. Virus is circulating in the blood, and till HBs antigen is positive, patient is infectious to others. Patient is infectious to others. Now, second antigen is HBe antigen. HBe antigen. So if it is positive, what does it mean? It will mean that patient is high infectivity. Patient is infectious to others. Patient is infectious to other with a high risk. With a high risk. So similarly, if it's antibody develop, patient become a low infective to others. Low infective to others. And we have done this marker HBx antigen. It is a carcinoma marker. It is a carcinoma marker. While the antigen HBc antigen, remember, it does not appear in blood. It does not appear in blood because it is surrounded by surface antigen. So isolated C antigen is never seen. C antigen is never seen. So this is the second set of question, which is the importance of serological markers, different serological markers. Now, if this concept is clear, let's come to the third set of questions, which ask about the diagnosis. That means combination of markers are given, like this antigen is positive, antibody negative. What is your diagnosis? So these are frequently asked questions. So to understand it, let's make a table. So three markers: HBs antigen, anti HBs, and anti HBC. These are the three most okay. So these are the three important viral markers: HBs antigen, anti-HBs, and anti-HBC. On the basis of these three, we can make a diagnosis. We can make a diagnosis. So let's see first combination. So this you can tell me the answer that will give me assurance that your concepts are clear. So first possibility is HBs antigen is positive in the blood, but antibody is negative, anti-HBC is negative. So tell me what is the diagnosis? Diagnosis means ki, whether it is acute, whether it is chronic, whether it is window period, incubation period, recovery period. So these are the diagnoses. So first is answer came incubation period of acute. Very good and very fast. So this is incubation period of acute hepatitis B. Very nice. Very good. Second is HBs antigen is positive and antibody is negative, but anti-HBC is IgM type. So now tell me, what is the diagnosis? What is the diagnosis? This is the serology. Window period, no, here you have missed one point, that during window period HBs antigen and its antibody both are negative. Both are negative, yes. This is a case of acute infection. Yes, this is acute hepatitis B. Acute hepatitis B. Now third is HBs antigen is negative, anti-HBs is also negative, but IgM is positive for anti-HBC. Now what is the diagnosis? Very good. This is a window period. Window period of acute hepatitis B. And also remember that window period is in relation to acute hepatitis B. Acute. Now fourth, let's see who will answer this. If you have not attended the foundation batch, so HBs antigen is negative, anti-HBs is positive, anti-HBC is IgM type. So tell me the diagnosis. What is the diagnosis here? Vaccinated, no. Just I make made a point that in vaccinated patient anti-HBC is not positive. Is not positive. Yes, this is a recovery period. Very good. this is a recovery period of acute hepatitis B. Recovery period of acute hepatitis B. Good. Now, fifth is HBs antigen negative, antibody positive, and this now become IgG type. So, what is the diagnosis here? That both anti-HBs and anti-HBc is positive. Yes, this is a case of chronic hepatitis B. Very good. This is a case of chronic hepatitis B. Then, sixth possibility, HBs negative, anti-HBs positive, and this is negative. Now, what is the diagnosis? Yes, this is post-vaccination. Post-vaccination. Oh, just there is some confusion in option number 5. In option number 5, HBs antigen was negative. Haldwani people has given it the accurate answer. HBs antigen negative, antibody is there, and IgG is there. This is not a chronic infection. Yes, this is a remote recovered. So correct this. This is a remote recovered. Very good. So, seventh, HBs antigen positive, antibody absent, and this is IgG type. HBs positive, its antibody negative, and anti-HBc is IgG type. So, the diagnosis is very good. It is chronic hepatitis B infection. Yes, it is a chronic hepatitis B infection. So, in these 7 combinations, we have covered each phase of the hepatitis B. Each phase of hepatitis B. Now, coming to the fourth set of questions, and that is on the replication, replicative markers. Replication markers. So let's understand replication markers. It means that virus is dividing, multiplying in the liver. So what will be its marker in the blood? Which will come? So these markers, if we'll say the quantitative marker. Quantitative marker means कि if the level of this marker is low, replication is low, and if the level of this marker is high, replication is also high. So this corresponds with the degree of replication, the severity of replication, and this quantity marker is a DNA. Now, because the level correspond with the quantity of DNA, so we'll say most sensitive marker of replication. Most sensitive marker of replication is again DNA. Then qualitative marker. Qualitative marker means if this marker is present, whether it is a high titer or a low titer, it does not matter. Only positivity, negativity matters. So this quality is HBe antigen. Then what are the other markers of replication? We all know that DNA is synthesized by DNA polymerase, so that can be detected in the blood. So other markers are DNA polymerase, Then it is the liver enzyme also, SGPT. If replication will be there, SGPT will increase, because replication is causing inflammation in the liver, and inflammation marker is SGPT. Also remember, not replicative marker, which frequently come in the question, not a replicative marker, and the answer is anti HBC. Anti HBC is not a replicative marker, not a replicative marker. Remember, like example, a patient is a say is chronically infected and is now a carrier. So in carrier we will get anti HBC antibody, which is of IgG type, but virus is not replicating inside the liver. Cirrhosis, there is no replication in the liver because liver is totally damaged, but we will get IgG anti-HBC along with HBs antigen. So this does not represent a replication. This does not represent a replication inside the liver. Anti-HBC, anti-HBC. And now coming back to one more important thing in the replication, and that is we have seen that HBe antigen is a qualitative marker, but sometime there are strain known as, which we have done earlier, pre-core mutant. Pre-core mutant means unable to synthesize. There is a genetic mutation, unable to synthesize HBe antigen. They are unable to synthesize this antigen, and these mutations, remember, mostly these mutation occur after infection. So that means when there was a inoculation into the body, HBe antigen was there, and that triggered its antibody formation. But during the course of disease, virus become mutated. This is a acquired mutation, we can say, and now HBe antigen will not be synthesized. So pre-core mutant, what happens? These patients, they are HBe antigen negative. This HBe antigen become negative even before its antibody completely neutralized this antigen. So, and anti HBe will be positive, because it occur after the mutation occur after the inoculation. So HBe antigen is negative, anti HBe is positive in pre-core mutant. But this possibility can also be the diagnosis that patient is having a low infectivity. Can also be a possibility that anti-HBe, they completely neutralize the antigen. So we just see the serology, the blood test. So why it is not a low infectivity patient? This combination, that HBe antigen negative plus anti-HBe is positive, can also represent a low infectivity, or can also represent a pre-core mutant. And remember, pre-core mutant, it is not a good sign. It is a rapid progression. So we will be deceived. How we will be deceived? that in pre-core mutant, virus is multiplying inside the liver, but the qualitative marker HBe antigen is negative because of the mutation, not because of neutralization by its antibody, but by the mutation. It become negative, which is not a good sign, because HBe antigen will be negative, and we will assume that the virus is not replicating, but indeed virus is replicating, and its surrogate marker HBe antigen is negative in the blood. So how to diagnose it? The best way to diagnose it, and this is a recent MCQ which has come, that HB antigen negative with anti-HB antibody positive can have two possibility. It could be a low infectivity, which is a good sign, or a pre-core mutant. Pre-core mutant. So to differentiate between these two, we will go for the replicative markers, other replicative markers, and what was the most sensitive replicative marker was DNA. So if in this presence DNA is negative, DNA is negative, we will call it as a low infectivity patient, that antibody has neutralized the antigen. But if this antigen has disappeared because of the mutation, here DNA will be positive, and we will call this as a pre-core mutant. Pre-core mutant, very important. In this combination, if DNA is positive, it is a pre-core mutant. If DNA is negative, it is most likely a low infectivity patient. Low infectivity patient. Also, here SGPT can also be elevated if there is a replication. If there is a replication, so which will further support that it is a pre-core mutant. Pre-core mutant. So remember, see the complete profile before concluding the low infectivity patient. It could be a pre-core mutant also. Pre-core mutant also. So these are the important serological markers. And one more thing is, when it is not able to synthesize, look, this I have just explained कि it occur after inoculation. So what happens? During the time of inoculation, HBe antigen was positive. So that has triggered the body to produce anti-HBe. So anti-HBe, it is started by immune system of the body. So initially these were having HBe antigen, but after some time it is the mutation which comes after inoculation. So gradually these become negative by mutation, by pre-core mutation. So initial trigger was there, therefore anti-HBe were positive due to initial trigger. Due to initial trigger, and we all know once antibody are triggered, they remain there in the body. Initially IgM, later on IgG, later on IgG. So even before anti-HBe were able to neutralize this antigen, it was converted into a pre-core mutant. Pre-core mutant. So they become HBe antigen negative, and the initial trigger remains. Initial trigger remains. These antibody will be present. So remember this concept. This pre-core mutant comes after the infection, comes after the inoculation. At the time of inoculation, E antigen was there, but over a period of weeks to months, it has converted into pre-core mutant. Pre-core mutant. So that has triggered the initial original antigen, has triggered the antibody formation, but later on it disappear on its own, not by these antibodies, not by these antibodies. So this is the concept of pre-core mutant. Concept of pre-core mutant, that it occur after inoculation. After inoculation. So the question is, how will we differentiate a chronic infection from a carrier state. Chronic infection of hepatitis B from a carrier state, how we can differentiate, or cirrhosis from a carrier state. How will we differentiate? So, what is the best investigation? Best investigation. How to differentiate a chronic infection from a carrier state or a cirrhosis from a carrier state? From a carrier state. Let's see who will answer. And if I get a correct response, we will take a break. Tea break will take. HBE antigen, HBS antigen, no. HBS antigen will be seen, we have discussed in all the stage, acute, chronic, cirrhosis, carrier state. IgM, no. IgM will not be able to distinguish because in chronic IgM will not be seen, carrier it will not be seen. SGPT and DNA titers, no, no, no. So I am not getting correct response. HB antigen, HBC, no. It will not be the best investigation. No, no. So this is a tip. Ki yes, who is this? Which center? Belgaum. So this is a correct answer. This is a correct answer. Very good. So best investigation to distinguish these is a liver biopsy. Serological markers, with the help of serological markers, can't 100% distinguish between these comparisons. Between these comparisons, 100% we can't distinguish. So the best answer is biopsy. So this is a tip ki how to read medicine. Medicine is should be read with a broad mind, broad vision. So we were talking about serology. So our focus was limited only on the serology, but the question was best investigation. So answer is biopsy. Answer is biopsy. So that will reliably distinguish these set of comparisons. These set of comparisons. So remember, there can be some chronic infections which are we can say low replication. So DNA can be negative here. Carrier state DNA can be negative here. So DNA can't distinguish. HB antigen can be negative here, can be negative here. So we can't distinguish. So the answer will be biopsy, which reliably distinguishes these comparisons. These comparisons. So because you have given me the correct answer, and thanks to the Belgaum Center, so we will now take a tea break. And after tea break, we'll resume with hepatitis C. Hepatitis C. So moving further, so question is differentiation between chronic and carrier state in biopsy. In biopsy, chronic infection will show inflammation, while carrier state there will be no inflammation in the liver biopsy. So moving on to next virus, and that is hepatitis C. Coming to its mode of transmission, and the primary mode of transmission for hepatitis C is percutaneous. And again two main needle and blood transfusions. and blood transfusion. So the needle stick injury risk of developing the infection from an infected needle. Infected needle is 1.8 to 6% is the risk, while in blood transfusion the risk is 1 in 18 lakhs of blood units transfused. Blood units transfused. So this is 1 in 18 lakhs, which is less than the risk in hepatitis B. So the risk is more in hepatitis B than hepatitis C. Now other mode of transmission are vertical mode of transmission, where the risk is approximately 5%, or sexual mode of transmission, where the risk is again 5%. So these are the percentages, very important percentages to know about the risk of transmission, and for B and C respectively. Now coming to the unique clinical features. So tomorrow there is PGI exam. Will there be a class tomorrow? Yes, class is scheduled for tomorrow, and that is a 9 to 9 class. So unique clinical feature of hepatitis C, first is most common thing that we'll do for hepatitis C, and this is the most common viral cause of cirrhosis. Most common viral cause of cirrhosis is hepatitis C. Also, this is the most common acute viral hepatitis leading to chronicity. Most common acute viral hepatitis leading to chronicity means the maximum chances of chronicity is in hepatitis C. Then third is, it is associated with unrelated diseases, and these diseases are, let's see, cryoglobulinemia, okay. Question is epidemiological marker, and epidemiological marker is anti-HBC antibody. Anti-HBC antibody is the epidemiological marker. Then cryoglobulinemia, it is porphyria cutanea tarda. Porphyria cutanea tarda. Then Sjogren syndrome, is associated with hepatitis C, as well as lichen planus. So these are the four disease associated with hepatitis C. Now there are some more associations have come besides these classical diseases with hepatitis C, and this is a potential question is, and that can come in tomorrow PGI exam also, and that is hepatitis C, it causes insulin resistance. It causes insulin resistance by inhibiting signaling pathway of insulin. Hepatitis C. And now the risk or we can say the increased association of hepatitis C is seen with not the causative agent, not the causative agent, but a association. Risk association is seen with non-Hodgkin's lymphoma. So we have seen Hodgkin's lymphoma was with B and non-Hodgkin's lymphoma associated with C, associated with C. Not a direct causative agent, but the association or the coexistence, coexistence. Now coming to its serology of hepatitis C. So serology is relatively simple for hepatitis C, and same first we'll see the time sequence of serological marker. We'll make a graph. This is the time period, and again in weeks. This is the inoculation. And these are the symptoms. So as a single point value, we can take the symptom as 10 weeks, at 10 weeks. So before 10 weeks, there is elevation of serological marker, and single point value will take it as 8. But this is also variable. That can be 6 weeks before or maybe 2 weeks before the symptoms. So there is a range. Anywhere it can originate, but as a single point value, we'll take at 8 weeks. At 8 weeks can be a 6 week or can be a we can say more than 8 weeks. More than 8 weeks. So this marker is elevated in the blood, and that is a RNA, SCV RNA. And this is the gold standard. For diagnosis of hepatitis C, gold standard is RNA. And just after the onset, at the onset of symptom or just after the onset of symptom is the elevation of anti-HCV. Anti-SCV. So these are the markers which are elevated. These are the markers which are elevated. So after the break, just as a repetition, first is the mode of transmission. Mode of transmission main is percutaneous. Percutaneous can be a needle or blood transfusion that we have discussed. Percutaneous, the risk is in needle-stick injury. Percutaneous needle-stick injury, the risk is 1.8 to 6%. 1.8 to 6%. While for blood unit or blood transfusion related, the risk is 1 in 18 lakhs. 1 in 18 lakhs of screened blood transfused. Screened blood transfused. Then we did the vertical transmission, risk is 5%. For sexual mode of transmission, risk is again 5%. Risk is 5%. Then we did unique clinical features. In unique clinical feature, most common thing associated with hepatitis C. So hepatitis C is the most common viral cause of cirrhosis. Most common viral cause of cirrhosis. Second, it is the most common acute viral hepatitis leading to chronicity. Most common acute viral hepatitis leading to chronicity. Third point, it is associated with unrelated diseases, and traditionally there were 4 diseases which were associated with hepatitis C. So it is associated with first cryoglobulinemia, associated with Sjogren syndrome, associated with lichen planus, associated with porphyria cutanea tarda. Porphyria cutanea tarda. So four disease: cryoglobulinemia, lichen planus, porphyria cutanea tarda, Sjogren syndrome. And recently discovered is, that is a point number fourth, hepatitis C causes insulin resistance, that it inhibits the signaling pathway of insulin, and now it is associated with non-Hodgkin's lymphoma, not as a causative agent but just increased prevalence. In the serology, inoculation, symptoms, and before the onset of symptom, during incubation period, there is elevation of RNA. Which is considered as the gold standard. And at the symptom onset or after the symptoms is anti-SCV. So incubation period, we have taken a point value of 10 weeks, though it can range. There is a range of incubation period, but a point value 10 weeks. Point value is 10 weeks. Now coming to the questions on serological markers, we can make a diagnosis. So that is dependent on the RNA and anti-HCV. RNA and anti-HCV and the diagnosis. So first possibility, RNA is positive but antibody is negative. So from this graph we can make a diagnosis that it is a diagnosis of incubation period. Very good. Second, RNA is positive and anti-SCV is IgM type. So which infection it will become? Acute infection. Acute hepatitis C. Third possibility, RNA is positive and anti-SCV is IgG type. Yes, it is chronic infection, chronic hepatitis C. Fourth, RNA is negative and anti-SCV is IgG type. So IgG we have seen indicate three possibilities. Chronic hepatitis, true. So we'll say it is a chronic hepatitis when RNA evidence is there, virus is still there in the body. Second possibility was remote recovered infection. So RNA has disappeared, so it is a remote recovered infection. Yes, very good. Remote recovered. But not vaccination, because till now there is no vaccination for hepatitis C. So these are the four possibilities of markers and the diagnosis of hepatitis C. Now coming to next virus, and that is hepatitis D. So let's see mode of transmission. Remember, hepatitis D is we can say usually undiagnosed in cases. So the mode of transmission is exactly, percentages are not known. So mode of transmission, it is dependent on the endemic area where the transmission occur through close contact, or it can be non-endemic areas where the transmission occur through percutaneous route. that is through blood or needle stick injury, and risk is variable. Risk is variable. So why vaccination is not developed for hepatitis C? Answer is the same, कि why vaccination is not developed for HIV. Then unique clinical features. Unique clinical features. So we start with the most common. We start with most common. So most common thing associated with hepatitis D, it is the most common cause of acute viral hepatitis leading to most common cause of acute viral hepatitis leading to fulminant hepatitis. Leading to fulminant hepatitis. And the definition of fulminant hepatitis is encephalopathy within 2 weeks of jaundice. Within 2 weeks of jaundice. Now, why it is the most common acute viral hepatitis leading to fulminant hepatitis? Because the reason is in second point, and second point is it occur with hepatitis B always. It occur with hepatitis B always because it require hepatitis B. It require hepatitis B. So remember this very important point. Two viruses simultaneously, they cause more fulminant hepatitis than a single virus. And hepatitis D means mandatory that there are at least 2 viruses in the body. 2 viruses. So hepatitis D assumes that for all practical cases it is a 2 virus. One is B and one is D. One is D. So 2 viruses, more pathology, more severity, more fulminant rate. More fulminant rate. Now coming to the serology. So serology will depend upon the type of infection that hepatitis D is causing. So serology it can be a co-infection, co-infection means that hepatitis D is acute hepatitis D plus chronic acute hepatitis B. Co-infection means both the viruses are coming simultaneously in the body, simultaneously. So acute hepatitis D plus acute hepatitis B is a co-infection. So the serology of acute hepatitis D, it is acute, so it will be IgM. Hepatitis D is anti-HDV. Anti-HDV. While acute hepatitis B is IgM anti-HBC. IgM anti-HBC. So this is the combination which will tell us that it is a co-infection. It is a co-infection. While superinfection, superinfection means that it is a acute hepatitis D. So hepatitis D is acute, but chronic hepatitis B superimposed on chronic hepatitis B. So the serology here will be IgM anti-HDV plus IgG anti-HBC. IgG anti-HBC is chronic hepatitis B. Chronic hepatitis B. So this serology will differentiate a co-infection from a superinfection, and HBS antigen will not be able to distinguish co-infection or superinfection, because HBS antigen can be positive in acute, can be positive in chronic also. So it is not able to differentiate. Now coming to the next virus, and that is hepatitis E. Hepatitis E. So hepatitis E, let's do mode of transmission, and it is fecal-oral and not blood transfusion, not blood transfusion. So mode of transmission is only fecal-oral. And the characteristic feature of this transmission is transmission to close contacts. Is rare. Transmission to close contact is rare. Close contact means living in the same household, in the same day care center. So this transmission is a rare transmission, because it is transmitted by a sewer line, and it affect a community. The distant neighbors or community will be affected. So let's see its unique clinical features. This is the, let's see, most common. This is the most common cause of acute viral hepatitis in adults. Most common cause of acute viral hepatitis in adults. Second, it increases the risk of fulminant hepatitis, increases the risk of fulminant hepatitis in pregnancy. Reason is not known. How does pregnancy as a host will increase the fulminant rate of this hepatitis E infection. Coming to the serology of E, IgM anti-HEV, IgM anti-HEV, and this represent acute hepatitis E. IgG anti-HEV. Remember, out of 3 possibilities of IgG, and 3 possibilities were chronic, remote recovered infection, or vaccination. Remember, hepatitis E does not cause chronic. So this representation can be a remote infection. About vaccination, there is no vaccination developed for hepatitis E. So the only possibility of IgG anti-HEV is a remote infection, and we'll say the patient is immune. And immunity comes only through the natural infection. Now coming to the complications, and in the complication important is to remember the percentages as a one liner question, so if we'll compare all the viruses, these are the complications of acute viral hepatitis. Complications in A, B, C, D and E. So first complication is fulminant hepatitis. Is fulminant hepatitis. So fulminant hepatitis, we have seen that it is a encephalopathy within 2 weeks of jaundice. So the rate in A is 0.1%, 0.1%, while similar rate is seen in hepatitis C, 1%, 0.1%. So the rate is same of fulminant hepatitis, and this we are talking about the acute hepatitis virus. So what is the difference between pre-core mutants and core mutant? Simple answer, pre-core mutant they are HBe antigen negative, while core mutant means core region is affected, the HBC antigen region is affected. So that is the difference, in the site, So about B, fulminant hepatitis rate is 0.1 to 1%, 0.1 to 1%. In D, fulminant rate for co-infection is 5%, and for a superinfection it is up to 20%. It is 20%. For E, fulminant rate for non-pregnancy, in E 1 to 2%, while for pregnancy it is 10 to 20%. 10 to 20%. So if a question comes कि the most fulminant acute hepatitis, and nothing is mentioned whether it is a co-infection or superinfection or hepatitis E, pregnancy, non-pregnancy. So the most common cause of fulminant hepatitis in acute viral hepatitis is always marked D. Is the most common virus with fulminant rate, highest fulminant rate. And if we have to compare head to head superinfection from pregnancy, so on an average the risk of superinfection is more than on an average the risk of pregnancy, So average risk of fulminant is in super is more than the pregnancy of E. So D is the most common cause. Coming to the other complication, and that is the risk of chronicity. That after acute hepatitis, what is the rate of conversion into a chronic state, So for A, the risk of chronicity is 0%. E is 0%. D is variable. While for B, chronicity risk is 1 to 10%, and it is for adults. But if neonatal infection, We have seen the risk as 90% in neonates, while in adult population the risk is 1 to 10%. For C, it is 85%, whether in adults or whether in children. It is almost same. 85% people turn into chronic hepatitis C. Chronic hepatitis C. Now, coming to the carrier state. A never cause carrier state, E never cause carrier state, D is a variable infection, variable chances. So, carrier means, if we'll see the exact definition, carrier is the organism or the virus is not causing damage into the liver but is still there in the body, while chronicity means it is causing inflammation in the liver. So when the chronicity chances are so high in C, 85%, so the carrier risk automatically goes down, because if one is a chronic, can't be a carrier. So here the risk, if we'll see, compare with B and C, the risk of carrier state in B is more than in C. So these are the percentages which are important percentages, usually asked maybe as a one liner or maybe given in the option as true or false. And coming to hepatocellular carcinoma, 0% risk by A and E, and again B has more risk than C. Hepatocellular carcinoma. Now coming to the treatment. In the treatment, we all know it is mainly a supportive treatment, like we have to take care of the nutrition, IV fluids, this is the mainstay of treatment, and importantly antiviral drugs. Remember, most of the cases, if we'll say, of acute hepatitis, most of the cases, they are self-limiting, except for hepatitis C, where the risk is of chronicity is very high. So antiviral drug we do not give for acute cases. Antiviral drugs, acute cases we avoid because most of them are self-limiting. But if it is a hepatitis C, then we give antiviral because the risk of chronicity is high. So these antiviral are given only for acute hepatitis C. Only for acute hepatitis C infection. So which antiviral drug we give? We give interferon. And today, if we are saying interferon, it is pegylated interferons. Pegylated means the duration of action is prolonged. We can plus minus, but not mandatory, can add ribavirin. So interferon plus minus ribavirin, and the duration of treatment is 12 to 24 weeks. So this is the treatment that we can give in acute hepatitis. By rest of the virus, we usually avoid giving antiviral treatment. Now coming to the last section of acute hepatitis is the prognostic markers. So these prognostic markers can be clinical markers, And there are three important clinical markers of poor prognosis, and that is ascites, uh, asterixis, and absent or decreased liver dullness. So A, ascites, asterixis, absent or decreased liver dullness. So asterixis is seen in encephalopathy and also known as flapping tremors. Flapping tremors. Seen in encephalopathy, hepatic encephalopathy. Absent or decreased liver dullness suggests liver necrosis. Liver is shrunken. There is a necrosis of the liver. So this suggests necrosis. Now, biochemical prognostic markers. Biochemical prognostic markers. So, most important, this is MCQ, and another MCQ related to this prognostic marker is associated with the increase mortality. So this is the most important and we can say which predict the maximum chances of mortality is this marker, and that is a prothrombin time elevation. Prothrombin time elevation. And others are hypoglycemia, hypoglycemia. It indicates that glycogen reserve they are absent in the liver because of liver damage. So when glycogen is not there, patient is vomiting. So more chances of hypoglycemia. And third is increased in serum bilirubin. Increase in serum bilirubin. And also remember the markers which are not poor prognostic markers. Again important and asked in the question. So what are the markers which are not poor prognostic markers? Not poor prognostic marker, and these are the levels of SGPT, SGOT, serum ammonia levels. These are not prognostic markers. But importantly remember that if it is a serum ammonia level, yes, it is not a prognostic marker, but if they give arterial ammonia levels, so this is a recent addition. Arterial ammonia levels, they correlate with severity. This has been recently discovered. The arterial levels, not the serum levels, not the serum level of ammonia, they does correlate with the severity. So these were the important points for acute viral hepatitis. So before going on to the chronic hepatitis, let's do some important questions, and let's see who will give the accurate answer first. So tell me, uh, which is not transmitted by blood, which is not transmitted by blood. Read the options carefully. Read the options carefully. Before options, this can be a wrong answer. Let's see. Hepatitis A, hepatitis B, hepatitis C, hepatitis D. So, what is your now answer? Which is not transmitted by blood, not transmitted by blood. So, answer is the common mode of transmission of B, C and D is blood, while A is a rare, and these are common. So, in these options, you should be very opportunistic. So, here your answer should be A, because these are commonly transmitted by blood. While if question is same and options are hepatitis A, B, C and E. Now, what will be your answer if options are changed? Yes, very good. So, now you mark E, because E is not seen, transmitted by blood. A is rare. So, out of rare, where it is a possibility and not, you mark not. Let's see the third options. Question is same. Hepatitis A, B, C and G. So what is your answer now? Yes. So the answer here is A. Answer is here is A. Then question is slightly changed and question now become all are transmitted by blood and causes acute viral hepatitis except. So options are hepatitis A, B, C, G. So what will be your answer now? Yes, answer will be no. C we have discussed is a cause of acute viral hepatitis. So out of this the answer will be G, though G is transmitted by blood, but remember it does not cause acute viral hepatitis. So answer will be A is rarely transmitted by blood but can cause acute viral hepatitis. So you should be very careful in comparing the options and putting the answers. Now, next question. Which clinical feature is present in a case of, remember, read questions very carefully, isolated Which clinical feature is present in a case of isolated unconjugated hyperbilirubinemia? Options are pigmented gallbladder stones, peripheral smear showing spherocytes, past history of gout, or all the above. Read question very carefully. Which clinical feature is present in a case of isolated unconjugated hyperbilirubinemia? Hyperbilirubinemia. So, what is the answer? So, answer is yes. Oh, Vishakhapatnam has given the answer correctly. It is D. It is D. Reason being, pigmented gallstone is a complication of hemolytic anemia. True. So, patient has developed pigmented gallstones. Second, spherocytes is seen in hemolytic anemia, like hereditary spherocytosis, autoimmune hemolytic anemia. They have spherocytes. Now, past history of gout. So, in gout, there is one drug which is can be given not in the acute attack but as a prophylaxis of gout, decreases the uric acid level, uricosuric agent, and that is probenecid. And we have seen that probenecid was the drug which was causing a decreased uptake of unconjugated bilirubin in the first section. So, answer is all the above. Answer is all the above. So, in these question, if you are getting a slightest hint of that clinical disorder and one option is written as all the above, so mark all the above. That will be the best answer. That will be the best answer. Now, coming to next section of liver, and that is chronic hepatitis. And chronic hepatitis cirrhosis, we will cover it as a one topic because the causes, etiologies leading to chronic hepatitis, they have a potential to cause cirrhosis also. So, chronic hepatitis or cirrhosis as a one topic, and we go one by one systematically. So, starting with the first cause of this is a topic of chronic hepatitis or cirrhosis. First is most common cause of cirrhosis worldwide, and that is alcohol. So, first is the alcohol. Alcoholic liver disease. So, let's start with what are the points being asked and what you should know and understand about alcoholic liver disease. So, starting first with the pathology. So, our sequence will be the same in all the etiologies like pathology, clinical features, investigation and treatment, and we will do the specific things about these etiologies. So, first is the pathology of alcoholic liver disease. So, in the pathology, we'll start with the dose. Ki what is the dose of alcohol which causes cirrhosis? So, cirrhosis causing dose of alcohol, and that is 80 to 160 gram per day. Remember, it is in gram, not in ml. not in ml, and that too for 10 to 20 years. 10 to 20 years. Not all alcoholics develop cirrhosis, but this is the requirement, minimum requirement. So 80 grams for 20 years will cause cirrhosis, but in order to achieve target early, 160 grams for 10 years will do that. So it's hard work, and this dose is for males. It is for males, while for females dose is half, 40 to 80 grams per day for the same duration for females. Female liver is more sensitive to the effect of alcohol, Then, so this was about the dose of alcohol which causes cirrhosis. Let's see what are the. So 1 gram equal to how much of ml? So this I think males among you will tell me, or boys will tell me ki if it is a whiskey, remember this is in percentage, like 40%. So percentage will determine the gram. For example, 40% means 40 gram in 100 ml. So to make it 80 grams, consumption should be 200 ml per day. So remember, this depend on the ethanol or the alcohol concentration, ki how much is it. So the ml will change. For beer, the ml will be even further high, because beer contains 6% or 8%, something like that. So it will be, and which preparation contain maximum percentage? So anyone can tell me which preparation, whether rum, whiskey, beer, contain the maximum? Gin, how much percentage? Vodka, gin, I think it is vodka. Which contain the maximum percentage of ethanol. So it is vodka. Now coming to the stages of alcoholic liver disease, it undergoes 3 stages. First stage is the fatty liver. Then hepatitis phase, and then comes the cirrhosis phase. So let's see what is the mechanism of these stages, because sometimes the treatment will depend on the mechanism of pathology. So remember, in biochemistry we have learned the basics that alcohol is metabolized to aldehydes. This we all know. With the help of first step is alcohol dehydrogenase. Second enzyme is aldehyde dehydrogenase. So aldehyde is produced, and aldehyde is a source of production of triglycerides. So, and where is alcohol dehydrogenase located? It is located in the liver. So the enzyme and the metabolism of alcohol occur in the liver. So there will be more aldehyde, and that is a substrate for triglyceride formation. So fatty liver is because of triglyceride deposit in hepatocytes. Hepatocytes. And this triglyceride deposit is responsible for fatty liver. Responsible for fatty liver. Also, sometime what happens that aldehyde binds with some proteins and that forms aldehyde adduct. Aldehyde adduct, and that product causes oxidative injury. Aldehyde adduct, oxidative injury, and any sort of injury leads to inflammation. And which is hepatitis phase. And this inflammation is mediated by a very important marker, TNF alpha. In treatment, we target this cytokine. We target TNF alpha. So remember this, it is a important pathology question. Hepatitis phase is mediated by TNF alpha, and oxidative injury in the liver is by this aldehyde adduct, the complex of aldehyde with the proteins. Now, if there is a chronic intake, this inflammation will turn into a chronic inflammation. And we all know in chronic inflammation, which cells will be recruited? A type of fibroblast will be recruited. Fibroblast recruited in chronic cases. And when fibroblasts are recruited, they will cause fibrosis and predispose to cirrhosis. So through this mechanism, alcoholic hepatitis occur. So we have done the mechanisms. First is the triglyceride deposit in the hepatocyte. And triglyceride, how they are deposited? By aldehyde. And how does aldehyde formed? From alcohol, ethanol. That metabolized first through alcohol dehydrogenase, acetaldehyde, and then aldehyde through aldehyde dehydrogenase. So there is a triglyceride deposit in the hepatocyte which causes fatty liver. And aldehyde, they bind with some proteins and form aldehyde adduct complex. This complex aldehyde adduct is responsible for oxidative injury, and oxidative injury through TNF alpha cytokine leads to hepatitis phase, the inflammatory stage. And chronically, fibroblasts are recruited. In any chronic phase, they cause fibrosis leading to cirrhosis. So other points to remember, that the triglyceride which are deposited, it causes macrovesicular fatty liver. Macrovesicular means, suppose this is one hepatocyte and this is the fat or triglyceride which is deposited. Remember, this fat is occupying the whole cytoplasm of the liver cells, almost all of the liver cells, and it pushes the nucleus to the periphery. Nucleus is pushed to the periphery and they occupy almost whole of the liver cell, that is hepatocyte. And this type of fat deposit, we call it as macrovesicular vesicular fatty liver. We call it as macrovesicular fatty liver when there is a lot of fat inside the liver. Now about the some points on the cirrhosis also. So these were the stages and mechanisms. So let's see points on cirrhosis. What is the type of cirrhosis? Type of cirrhosis. It is a micronodular cirrhosis. This is a micronodular cirrhosis, and the reason is why when we label it as a micronodule, when the size of the nodule, the regenerating nodule, is less than 3 mm. Is less than 3 mm. The nodule size, the regeneration of the nodule is low, and this occur because of alcohol intake. So alcohol inhibits the regeneration of the nodules. So regeneration power is reduced by the effect of alcohol, because alcohol is a toxin. So it inhibits the regeneration growth. There is only one advantage of this inhibition of regeneration. Risk of carcinoma, hepatocellular carcinoma, is reduced because regeneration is less. So the risk will be less of carcinoma. But if patient stop alcohol, cessation of alcohol, this will convert into macronodular. Cirrhosis, because the inhibitory effect of alcohol has gone, but risk of hepatocellular carcinoma will increase in macronodular cirrhosis. So patient now will have two choices. First choice, continue with alcohol and die from cirrhosis, or stop alcohol and die from carcinoma. So which path will patient choose? Patient will choose continue alcohol and die from cirrhosis. So this has a very important implication in the treatment aspect. Means once an alcoholic, always an alcoholic. So that we'll see in the treatment aspect. Now another more point on the pathology is the lobe involved. Lobe involved in liver characteristically is the left lobe. Most of the liver disease they have right lobe involvement, but this is a unique feature of alcohol that predominantly it affects the left lobe, and there is no mechanism, no reason for that. Now this point will come when we will call a person alcoholic or ex-alcoholic, that will be in the treatment aspect. So clinical feature, and we'll do only the unique clinical features of alcohol hepatitis or alcoholic liver disease. So first will be peripheral neuropathy. There are very few causes of cirrhosis which cause peripheral neuropathy, and alcohol is one of them. So This peripheral neuropathy is due to the effect of both direct alcohol effect. Alcohol is toxic to the nerves, and because of alcohol there is a deficiency of pyridoxine. So deficiency of pyridoxine causes peripheral neuropathy. Second, and this is a potential question because it has introduced into Harrison, the latest edition of Harrison, and that is Jeeves syndrome. Jeeves syndrome. So whenever a question comes, Jeeves syndrome, answer will be alcoholic liver disease. So let's see what is the meaning of Jeeves syndrome. Jeeves syndrome is a deep jaundice due to the effect of two pathologies going on simultaneously, and this deep jaundice is because of the effect of hepatitis, which is causing a elevation of predominantly conjugated bilirubin, hepatocellular damage. Secondly, this jaundice is also because of the effect of hemolytic anemia. And hemolytic anemia causes elevation of unconjugated bilirubin. So one side hepatitis causing conjugated and second side hemolytic anemia is causing unconjugated. So the total bilirubin is markedly elevated. Both the components. And we all know why does hemolytic anemia occur in alcohol? Because alcohol induce membrane changes of RBCs, and just remember these membrane changes of RBC as acanthocytes, which are irregular spikes on RBC membranes. Irregular spikes on the RBC membrane, acanthocyte, and that is because of the effect of alcohol, and this is acanthocytes, RBCs. Now about the characteristic investigations. In cirrhosis, we will in alcoholic cirrhosis we will not do the non-specific signs like Palmer edema, spider angiomas, gynecomastia. These are seen in all other cases of cirrhosis. They are not specific for alcoholic cirrhosis. So in the investigation, again we will do the specific investigations only, not ki bilirubin is high, albumin is low. These are seen in all other causes of cirrhosis. So the specific feature is, first and very important, the ratio SGOT upon SGPT ratio. So in most of the liver disease, this ratio is less than equal to 1. Is less than equal to 1 in most of the liver diseases. But in alcoholic liver disease, this ratio is more than 2, which is highly specific for liver disease. So this ratio more than 2 is highly specific for alcoholic liver disease. Alcoholic liver disease. And the reason is because there is a deficiency of pyridoxine. This lead to decreased synthesis of SGPT. It is a co-factor for the synthesis of SGPT. So SGPT synthesis will be reduced, and SGOT will elevate uninhibited. So SGOT elevation is more than the elevation of SGPT. So the ratio will become more than 2, which is highly specific for alcoholic liver disease. Then second, again this is wrongly given in your guidebooks, that is the Mudit Khanna or maybe Amit Ashish, and that second point is the elevation of gamma glutamyl transpeptidase. Short form is gamma GT. Elevation of gamma glutamyl transpeptidase, and that occur because of due to obstruction. And how does this obstruction occur? Because of fatty liver. Because of fatty liver. So what is happening? Suppose these are the two hepatocytes, normal hepatocytes. Intrahepatic bile flow is normal. Bile flow is normal through these hepatocytes. But when there is a fatty liver, what happens? The size of these hepatocyte increases because of fat deposit. Because of the fat deposit. So what will they do? They will decrease bile flow, and there is a sort of bile obstruction due to compression of intrahepatic bile ductules. So bile flow is decreased due to fatty liver. They become swell up, so they compress, and this leads to gamma GT, which is a marker of obstruction. And remember, this gamma GT is a non-specific marker of, we can say, obstruction, or it is also a non-specific marker of fatty liver, which can be alcoholic or non-alcoholic. So it is a non-specific marker, not a specific marker of obstruction or fatty liver. And fatty liver can be because of both alcoholic and non-alcoholic etiologies. So it is not a marker of alcoholism too. It is not a marker. Now coming to the third point and third investigation, and that is peripheral neutrophilia. That is a peripheral neutrophilia. Remember, alcoholic hepatitis is a chronic disease, but still we get neutrophilia. Reason being that these neutrophils, they spill over, from hepatocytes. Means there is so much of inflammation going inside the liver that the neutrophils, they spill over from these hepatocyte into the peripheral circulation, and this finding is associated with poor prognosis. Poor prognosis in cases of alcoholic liver disease. Now the fourth investigation which we'll try to do in every case of chronic hepatitis, and that will be liver biopsy. So we'll try to see the specific feature of liver biopsy in each chronic liver disease. So it depends on the stage. If it is a fatty liver, we will get a macrovesicular fatty liver. If it is a hepatitis phase, then what we'll get? We will get a perivenular. So these perivenular hepatocyte, they show maximum inflammation, perivenular inflammation. And reason is, these perivenular hepatocyte is the site of alcohol dehydrogenase. It is a site of maximum alcohol dehydrogenase, so enzyme is there maximally, and that will cause the inflammation in that portion, maximum. While we can also see Mallory hyaline bodies. Mallory hyaline bodies can also be seen. These are the eosinophilic inclusions. Mallory hyaline bodies. But remember, they are also seen in other cases, like they can be seen in cases of non-alcoholic fatty liver. They can be seen in cases of Wilson's disease. Can be seen in Indian childhood cirrhosis, can be seen in hepatocellular carcinoma. So there are many list of Mallory hyaline bodies. So it is not specific for alcoholic hepatitis. Then in the cirrhosis phase, we'll get to see a typically a micronodular cirrhosis. So do not confuse between a macrovesicular fatty liver and a micronodular cirrhosis. These are two different things seen in alcoholic liver disease. Now coming to the treatment aspect. So treatment will depend on the stage. If it is a fatty liver, the treatment consists of only cessation of alcohol. And fortunately this is reversible. This is a reversible stage after cessation of alcohol, and as such no drugs are required in this condition. Then hepatitis. So there is so much of inflammation which is going inside the liver, that we need a very high potency steroid, high potency anti-inflammatory agent, which is a steroid. So in hepatitis phase we give steroid. So this is hepatitis where steroids are indicated. Steroids are indicated. And when will we start steroid? There is a specific indication. So indication of starting steroid in a case of alcoholic hepatitis is alcohol discriminant function more than 32. Alcohol discriminant function is more than 32. Then we start the steroid therapy, and the formula for alcohol discriminant function is 4.6 multiplied by prothrombin time of the patient minus prothrombin time control plus serum bilirubin plus serum bilirubin. So if it comes out to be 32, it is a poor prognostic marker, and in that case we start with the steroid to control inflammation. Then second drug that we can give in hepatitis phase is the marker, the cytokine was TNF alpha. So if we give TNF alpha antagonist, that will help. And this property we have seen in pentoxifylline. It has got a TNF alpha antagonist activity, and though this drug we have studied is used in peripheral vascular disease also, but has a characteristic effect of a mild TNF alpha antagonist activity with few side effects, or we can say minimal side effects. So this has become so useful that this is the drug which has reduced mortality in alcoholic liver disease, pentoxifylline, and reduce the chances of renal failure in alcoholic hepatitis. So this has become so useful drug for alcoholic hepatitis phase. Now the third stage, which is a cirrhosis stage. Remember, when cirrhosis occur, it does not respond to steroid or any immunomodulator drugs, anti-inflammatory drugs. So the best option here will be a liver transplant. Best treatment is liver transplant. But though patient is eligible for liver transplant, donor is available, hospital is ready, still these patients are not able to undergo liver transplantation. Remember, once an alcoholic, always an alcoholic. So what does that imply to the treatment of liver transplant? Remember, it is alcohol discriminant function means some another name of alcohol discriminant function. No, it is same. Alcohol discriminant function. It is a prognostic score for alcoholic hepatitis, which is dependent on the prothrombin values as well as the serum bilirubin. So one of the Dose of pentoxifylline, usually we start with 400 milligrams twice a day, then we can titrate it accordingly. So dose usually we start with the 400 milligrams twice a day. So cirrhosis, the best treatment will be liver transplant, but patient is not undergoing liver transplantation because once an alcoholic, always an alcoholic. So any role of hepatoprotectives, is they are overused drugs. They have not shown in any studies the role of these hepatoprotective drugs which we usually give in our clinical practice. Like we give hepamers, we give ursodeoxycholic acid. So there is no role. There is a role of antioxidants, but that too in non-alcoholic liver disease, antioxidants. Because what is the injury here? That is an oxidant injury, but still antioxidant they have not shown any benefit here. So cirrhosis, one of the absolute contraindication for liver transplant. One of the absolute contraindication for liver transplant is active alcohol use. So once an alcoholic, always an alcoholic. So patient is drinking alcohol, so creating contraindication for the liver transplant. So what does active use mean? Active use mean alcohol intake within last 6 months. Within last 6 months. So from liver point of view, we'll say the ex-alcoholic as though which has left alcohol for more than 6 months. So if there is a intake within the last 6 months, then it will be active alcohol use. So patient has to leave alcohol for 6 months, then patient will be eligible for a liver transplant. So these were the points on alcoholic hepatitis as a chronic hepatitis. Now coming to the second cause of chronic hepatitis or cirrhosis, and this is post-viral. And we have seen the viruses which are causing chronic hepatitis are hepatitis B, C and D. So we have done the important features, we have done the serology of these viral markers. So the most important part of post-viral chronic hepatitis or cirrhosis is the treatment aspect. So we'll do the treatment only here. So this treatment is practically very important, and in the MCQs this is also very important. How to approach a patient of hepatitis B? If you are reading MCQ books, you must have seen such sort of questions. Ki this is the positive, antigen is positive, SGPT values are this. So what is the next line of management? What is the next step? So we'll try to make it very simple with the help of flowchart, and you will be able to solve those type of MCQs. So first starting with the hepatitis B. So let's see, for hepatitis B, a patient is coming as a case of chronic hepatitis. Chronic include all the stages of hepatitis B, like it can be a just chronic inflammation, it can be a cirrhosis, it can be a carrier state. So that means it is a chronic infection. It is a chronic infection by serology. And by serology, what was the best marker? It was HBs antigen plus IgG anti-HBC. This is the serology for a chronic hepatitis B, for a chronic hepatitis B. So, such patients come, and it can be written that HBs antigen is positive for more than 24 weeks. That automatically become a chronic infection. So, we divide the patient it into two groups of a case of hepatitis B. One will be a non-cirrhosis phase, and second is a cirrhosis phase. So, non-cirrhosis, first we'll do the cirrhosis, non-cirrhosis phase here. So, next step is do SGPT levels. Remember, SGPT levels, they are high. They are indirect measure of inflammation in the liver. Inflammation in the liver. If there is any inflammation due to any cause, SGPT will increase. SGPT will increase. So, this is a representative marker of inflammation. It can be high. There are two possibilities, or it can be normal. So, what we have done, chronic hepatitis is coming. So, SGPT, which is a inflammation marker, it can be high or it can be normal. If it is high, so it means that when we will say it is high, it is more than 2 times upper normal limit. When it is more than 2 times the upper normal limit, then we'll say it is a high. Then it is a high. And what is the upper normal limit? 40 international units per liter. It is not key if it is 50 or 60, we'll say it is high. It will be considered as a normal. To be significant, it should be more than 2 times the upper normal limit. Upper normal limit. So, after SGPT, we will do a DNA level. And DNA, we have seen, it is a sensitive marker of replication. Replication. So, SGPT was inflammation, DNA was replication. So, in both the conditions, we will go for a DNA test. DNA test. Even if SGPT is normal, even if it is normal, we have to go for a DNA estimation. DNA estimation. So, DNA, there can be two results. One, it can be high or it can be normal. Normal means not detectable. Normal means it is not detectable. Here the possibility are same. DNA can be high or DNA can be normal. Can be normal. So, now we have 4 options. So, one by one, let's see what will be the next line of treatment in these cases. So, look carefully at the extreme left hand side possibility. Extreme left hand side possibility is SGPT is high, DNA is high. Extreme left. SGPT high, that means inflammation is there in the liver. DNA is high, that means there is a replication. Virus is multiplying in the liver and you target multiplying virus that will respond to antiviral treatment. So, here our next line of treatment will be antiviral treatment. Antiviral treatment straight away. Now, look at the extreme right side possibility. extreme right side possibility is SGPT is normal and DNA is normal. So that means there is no inflammation in the liver, there is no replication in the liver. That means patient is most likely a case of carrier state. Here the next is just observation, and observation we do with SGPT every 3 to 6 monthly. 3 to 6 monthly SGPT measurements, that is observation. But SGPT high, DNA normal, and SGPT normal and DNA high, so one parameter is abnormal. So our next step is liver biopsy. Liver biopsy. So if liver biopsy will suggest us that there is a inflammation going inside the liver, then we go for antiviral treatment. So in liver biopsy, we take a index, and that index is known as HAI, that is histological activation index. That is known as histological activation index, and this is a pathological index with many parameters. But for treatment point of view, just remember, when this histological activation index is more than 3, give antiviral treatment. If it is less than 3, observation. More than 3 mean the degree of inflammation, give antiviral treatment. Antiviral treatment. So what are the antiviral treatment available with us? Let's see, and we'll simultaneously do the questions on these antiviral treatment of hepatitis B. After that we'll do the treatment of cirrhosis phase. So first we'll see the antiviral treatment. So the principles, main principles of antiviral treatment. First is initiate antiviral treatment with monotherapy. So initiation is always with a single monotherapy. And which drugs we can choose from? So any one of 3 first line agents we can use. Any one of 3 first line agent we can use, and these first line agent first is interferon. Remember, interferon is still the first line agent. In the first line agent, it was the oldest molecule for hepatitis B. First molecule for hepatitis B still share the status of first line agent. So let's do some points which have already come in the questions. Interferon, we all know, is an injectable preparation. It is not effective in 3 conditions, and remember these 3 conditions, the question wise very important. Not effective in cirrhosis. So whenever a patient of cirrhosis come, do not give interferon. They are not effective. It is not effective in immunocompromised patients. And studies have shown that it is not effective for Asian children. Reason not known. कि why they are not effective in Asian children. So these are the subset where it should not be used. It should not be used. Now, second is Inticavir. It is oral drug. Inticavir is a oral medicine that we give, and it is the most potent antiviral from most potent antiviral agent, most potent antiviral agent for hepatitis B. For hepatitis B, this is for MCQ purpose. Then Inticavir, the thing is कि dose to be reduced in renal failure. Dose has to be reduced in renal failure. Also, they are not effective in lamivudine resistant cases. So if patient is coming with the failure of treatment with lamivudine, these agents should not be given because they are not effective in those cases. Effective in those cases. Also, they are not effective in YMDD mutation. Of hepatitis B. So this we'll see what is the meaning of this YMDD mutation, but just now here remember that they are not effective for lamivudine resistant cases as well as YMDD mutants of hepatitis B. Now the third first line agent is tenofovir. Third is tenofovir. So it is also oral. It is effective in lamivudine resistant cases, YMDD mutations, dose not modified in renal failure. There is no need for dose modification, and as a side effect they causes a mild decrease of bone density. Mild decrease of bone density. So these are the important points for tenofovir. So out of these three agents, if question comes, because we know that Indian examiners, they are having fascination for drug of choice, even though there is no drug of choice as such a single agent. So if they ask which is the drug of choice for hepatitis B chronic infection as antiviral agent, so out of these three, if we compare all these three drugs, the best drug or the drug of choice is tenofovir. Because it is effective in the resistant cases. It dose need not to be modified in renal failure, and it is a oral agent. And whatever is the side effect, that there is a mild decrease in bone density, can be tackled with conservative treatment. So coming to the sequence. So the sequence of antiviral, and that will give you the answer here. So the sequence is when we have started with the antiviral drug. So we have started with one antiviral therapy. monotherapy. So after 24 weeks, after 24 weeks, we do a DNA test. Monotherapy. So we have started the monotherapy and give it for 24 weeks. Do a DNA. If DNA copies, we do DNA copies. If it is less than 2000 per ml of blood, so target is less than 2000, which is undetectable, we can say, or we have achieved our target of inhibiting the replication of virus. So when it become less than 2000, continue the original monotherapy which we have started for at least 1 year. For at least 1 year, it should be given. It should be given. Then, interferon is the first choice among the first line agent. No. I think you have understood it wrongly. I said interferon was the first drug used for hepatitis B. You can say oldest drug, the first drug which was used, not the first choice. It was the first drug which was given for hepatitis B. So it is the oldest drug. It is the oldest drug for hepatitis B. So continue the monotherapy for at least 1 year. And usually on an average, the treatment is given for 1 to 2 years on an average. But minimum duration is 1 year. Now, if DNA copies is more than 2000 per ml, that means we have not achieved our targets. So what we'll do? We have two options. Either what we can do, we add another agent. That means now the treatment will become dual. So this is the only indication of dual therapy, that after 24 weeks we are not able to achieve our target of DNA. We can try mixed agent. We can try a second agent. So add another agent along with the original agent, and or change to another monotherapy. Change to another monotherapy means, suppose we have started with say entecavir, so change it to tenofovir. Or if we have started with interferon, then change it to tenofovir. So we can change to the another monotherapy, and after changing or combining the agent, same sequence will occur. After 24 weeks, do a DNA copies, and response is there, continue the same treatment. Response not there, then keep on changing the drugs or maybe adding another agents for hepatitis B. Now, some more questions on antiviral agents. So that will be including the YMDD mutation also, and that is highly important, especially for HIV, co-infection with HIV, which is asked. So so we'll take, just give me 2 minutes, we'll finish this antiviral for B. So safest in pregnancy and maximum viral resistance. Answer is lamivudine. So Tanda people is saying no break. So just for my information, can Tanda people tell me where exactly is the Tanda city located because you have more stamina than other people. So I can see ki, your water, your mineral intake is so excellent that you have a good stamina. Just tell me where exactly it is located. So just for this thing. So okay, so that is located in Kangra, Himachal Pradesh. Yes, and therefore you have such a good stamina, pure water, pure air, and yes, it is a mountain water effect there. Good. So because we are living in plains, so we are having polluted air, polluted water, polluted food, polluted fruits. Therefore, we have low stamina. So, safest in pregnancy and maximum viral resistance is seen with lamivudine. And one more thing is कि when there is a HIV plus hepatitis B. Hepatitis B. Now, Bareilly people are saying no break. So, HIV with hepatitis B, and when we give lamivudine as a monotherapy, lamivudine as a monotherapy, that result in YMDD mutation of hepatitis B, which make it more resistant to treatment plus increase progression. Increase progression. So for those who are giving PGI tomorrow, remember this is important potential question. कि YMDD mutation, remember, seen with after monotherapy of lamivudine with HIV. So this induces a change in hepatitis B that it become resistant to the effect of lamivudine and it become more progressive. So YMDD mutation, another question come, which will be a best drug? Answer is tenofovir, which we have discussed that tenofovir was effective in a YMDD mutation. So these are the points that you should remember for antiviral. Now we should take a break because I am living in the plains and my stamina is also low. So we'll take a 10 minutes break and then we'll continue with the rest of the hepatitis B cirrhosis phase. Okay, so today class will be till 9 o'clock. Now, coming to the second portion of hepatitis B, that was the cirrhosis phase. So YMDD mutation we have discussed, a progressive resistant mutant strain due to HIV co-infection, and if we give a lamivudine monotherapy, then there is this mutation. Now coming to the cirrhosis phase of hepatitis B, this we can divide it into two groups. One is a compensated cirrhosis and second is decompensated cirrhosis. Compensated means that there is no liver failure yet. So there are specific points to say that it is a compensated cirrhosis, and when there is a no liver failure, it means there could be some vital or viable cells in the hepatocyte which are taking the function of liver, and because of these viable cells there is no liver failure, and we have to protect those viable cells by the virus. So we have to inhibit the virus by antiviral agents, though there is a cirrhosis phase. So when we will say that it is a compensated phase, there are 5 criteria which should be fulfilled to call it as a compensated cirrhosis, and these are uh, ascites should be absent, encephalopathy should be absent, serum bilirubin less than 1.5, INR less than 1.5, and serum albumin. Serum albumin is more than 3.4. More than 3.4. So all these should be the criteria to label it as a compensated cirrhosis, and INR is international standardized ratio. This is a parameter for prothrombin time, international standardized ratio for prothrombin less than 1.5, which is a normal ratio. So if all these are fulfilled, then this is a case of a compensated cirrhosis, and in this phase we give antiviral drug to protect those cells, to protect the viable cells which are still there, and antiviral to be avoided will be interferon, because interferon we do not give in a cirrhosis phase. Now coming to decompensated phase, decompensated phase means liver failure is positive. And the best treatment for liver failure, if it is a cirrhosis phase, decompensated one, is liver transplant, which is done. But liver transplant takes some time, patient donor availability and everything matters. Till liver transplant is done, what we can do, we do a DNA level. So even if decompensated phase, if DNA is elevated, then give antiviral till liver transplant is done. Remember, the antiviral drugs will be useful if virus is multiplying. And where will virus be multiplying? Virus will be multiplying in the hepatocyte which are still not undergone fibrosis, or which are not affected by the cirrhosis. So remember this point, if whole of the liver is converted into a fibrotic organ or a cirrhotic organ, there will be no space left for the virus to replicate. So in a sense, if the complete liver has undergone into fibrosis, virus will not replicate inside the liver. So where will then virus live? Will it leave the body? No, it will not leave the body. Second site of virus in the body after liver is lymph node. So virus will go into the lymph node, but it will not replicate there. It will sit out there and it will keep on circulating in the blood. And when we transplant a new liver instead of a cirrhosis liver, it will again reinfect the transplanted liver. So DNA positive means that there are still some cells in the liver which can lead to we can say viral replication. So we give antiviral, so at least those minute pockets of liver, they are not affected by the virus, so viral replication we can inhibit. So is voice now clear, or is there any echo sound? All right. So again, antiviral should not include interferon here. Now coming to the treatment of chronic hepatitis C. So for chronic hepatitis C, what we'll do, we again divide the patient into two groups. So one is a non-cirrhosis phase and second is a cirrhosis phase. Chronic hepatitis C. So in non-cirrhosis phase, usually our aim is to give antiviral drugs. So indications of antiviral in non-cirrhosis phase is presence of RNA, and second is moderate to severe hepatitis oblique fibrosis on biopsy. So both these should be present, to call it as indication for antiviral, and now they have removed SGPT as a criteria for starting antiviral treatment. So SGPT is now out of the list. It is only RNA levels detectable and biopsy positive for mild to severe hepatitis or maybe oblique fibrosis, but not cirrhosis on liver biopsy. So what is the principles of giving antiviral? Here we give and initiate will dual therapy, and dual therapy consists of interferon plus ribavirin. So this is ribavirin is mandatory here. It is a dual therapy that we start, and depending on the genotype, if genotype is a severe genotype, duration will be more. So if it is a type 1 or 4, which are severe type of genotype, the duration of treatment is 48 weeks. If a genotype is type 2 or 3, which is a milder form, duration is less, 24 weeks. And unfortunately we do not have other treatment available, effective treatment available for hepatitis C. So there are no other options. So but we have to go for a lifelong treatment. Lifelong treatment is given for hepatitis C if hepatitis C is associated with cryoglobulinemia, because this cryoglobulinemia can recur anytime. So to suppress those antibodies, cryoglobulins, we have to give antiviral therapy lifelong. It is remember a very life-threatening condition, cryoglobulinemia. So we have to inhibit that life-threatening condition. So we give lifelong treatment with interferon and ribavirin. So here mandatory what we were giving the interferon, and interferon, they are not effective in cirrhosis. So once a patient develops cirrhosis for hepatitis C, next line of treatment is liver transplant. We can't give any drugs here. So the best treatment will be liver transplant, And as you can see, the indication of liver transplant here comes very early, relatively very early in the course of disease. So we can say the most common indication of liver transplant in adult cirrhosis is hepatitis C. Again, important question. So most common indication of liver transplant is hepatitis C in adult cirrhosis, and not alcohol, because alcohol patient, they have contraindication present, so we can't go for transplant in those patients. So this was post viral. Now coming to the third cause, and that is autoimmune hepatitis. And remember this topic, the question came just 6 days back in AIMS May exam on autoimmune hepatitis. That was a very simple question. So autoimmune hepatitis, if we'll see the pathology. So the pathology or liver damage is due to direct antibody damage. Direct antibody damage is responsible for autoimmune hepatitis pathology. So loss connection for chronic hepatitis C. So you can just briefly look at the flow chart, because other centers might be disturbed. This is chronic hepatitis C. You can note down the points because it is easy to understand. So just in 1 minute you can go through this flow chart. All right. So type 1, genotype 1, and is the most common hepatitis in India. All right. So autoimmune hepatitis is the third cause, and we have done the pathology. It is direct antibody damage. Now coming to the unique clinical features, and remember, only on the basis of unique clinical features we can make a diagnosis, and that was the question this time in AIMS. So from clinical feature, diagnosis was 100% clear, it was autoimmune hepatitis. So it is autoimmune, and this is seen in female. This is seen in female, and it is young female. So child pukes classification and other classification you will do in the liver transplant portion. So also the point which will clinch the diagnosis is this term called as recurrent. recurrent hepatitis. So if recurrent hepatitis is mentioned, it is a type of chronic hepatitis with recurrence maybe over a period of years, because the damage by the antibodies. So antibodies sometime become silent, sometime they cause pathogenesis. So it will be a recurrent sort of hepatitis, and this is a form of chronic hepatitis. Do not confuse it with the relapse. Relapsing is with A, recurrent is with autoimmune hepatitis. And most common viral hepatitis associated with autoimmune hepatitis is C. Most common viral hepatitis is seen with hepatitis C. Now coming to the investigations, and we'll do the specific investigations. So it depends on the type of autoimmune hepatitis and the antibodies. So type is type 1, and this is the most common type of hepatitis, autoimmune hepatitis. So antibody here is ANA. Other antibody seen is P-ANCA. Also anti smooth muscle antibody is also positive here. And just for the completion point of view, HLA association, again important because new addition. HLA associated with the type 1 autoimmune hepatitis is HLA DR3 and HLA DR4. These are the two HLAs which are associated with type 1. Now coming to type 2, antibody associated is anti-LKM1. Anti-LKM1, full form of LKM is liver kidney microsome. Anti-LKM1 is also positive in hepatitis C. It is positive in hepatitis C also, anti-LKM1. Now let's do simultaneously some other questions on this antibody only. So anti-LKM2 is seen in drug-induced hepatitis. While anti-LKM3 is seen in hepatitis D. So coming to the HLA association. So HLA associated with the 2 is HLA-DR-B1 and HLA-DQ-B1. So B1 is common. HLA-DR-B1 and HLA-DQ-B1 is associated with type 2. There is one more type, but that is so uncommon that it is virtually not seen, but it is least common. Importance only, just remember that antibody seen will be antibody against liver soluble antigen. Antibody against liver soluble antigen, and there is no HLA association with this type 3. Now let's try to define in the investigation liver biopsy. because we will try to see the specific feature in each chronic hepatitis. So the liver biopsy finding here is very characteristic, a rosette pattern of hepatocyte regeneration. Means first hepatocyte are damaged by the antibodies, and then when they will try to regenerate, they will regenerate in the form of a row or rosette pattern, the rose shaped or a flower shaped pattern of regeneration. This is so specific that diagnosis is 100% made on this finding, as well as if simultaneously there is increased plasma cells in the liver, so that will also favor autoimmune hepatitis. Now coming to the treatment. Treatment, if it is a hepatitis phase, this do respond with immunomodulators, and immunomodulator we give is steroid, and other immunomodulator, if there is no response of to steroid, we can use azathioprine, we can use mycophenolate also. So the question this time was young female with recurrent hepatitis and respond very well to immunosuppressive agents. So the diagnosis was asked, and it was autoimmune hepatitis. So now cirrhosis phase. If patient has entered into a cirrhosis phase, the treatment only option is liver transplant, because immunosuppressive will be not useful. So cirrhosis, we have to go for liver transplant because it will immunosuppressive agent will not be effective in a case of a cirrhosis phase. But unfortunately, after liver transplant, there is a chance of recurrence. So this is also one set of caution, कि after a liver transplant, which condition recur and which does not recur. So recur after liver transplant. Autoimmune hepatitis recur after liver transplant. So recurrence is common. But still we have to go for liver transplant because there is no other option left. Okay, from type 3, you can just see this slide in 1 minute. So type 3, the antibody, liver soluble antigen, and then we did the liver biopsy findings, rosette pattern of hepatocyte regeneration, highly characteristic with increased number of plasma cells, and treatment was steroid. Not responding, we go for azathioprine or mycophenolate, and in the cirrhosis phase we can go for liver transplant where recurrence is common. All right, so moving on to next chronic hepatitis is primary biliary cirrhosis. So again, same sequence of pathology. and we'll try to translate that pathology into unique clinical features. Okay, how does they translate into the clinical feature? So, primary biliary cirrhosis is remember is autoimmune pathology. So, if it is autoimmune, it will be more common in female. Yes, this is more common in female. Primary biliary cirrhosis. There is autoimmune fibrosis of intrahepatic bile ductules. Autoimmune fibrosis of intrahepatic bile ductules is seen. So, here already fibrosis has occurred due to autoimmune phenomena. Therefore, the female will be of middle age, slightly more age than the autoimmune hepatitis. So, it is seen in mainly middle age female. Range we can say is 40 to 60 years. 40 to 60 years. And because there is a fibrosis of intrahepatic bile ductules, there will be a bile flow obstruction. So, this leads to bile obstruction. Bile obstruction. And when bile is obstructed, the again a question, most common symptom occur of primary biliary cirrhosis, and that is pruritus. That is pruritus, most common symptom, and we can say this is also the earliest symptom. Earliest symptom. And through bile there is a cholesterol excretion also, we all know. So, cholesterol excretion also decreases because the process is same through the bile. So, if there is low cholesterol excretion in the body, cholesterol will increase, and this cholesterol will be deposited in say skin, or we can say extensor surfaces. So, cholesterol excretion decreases, leading to increased cholesterol in the body, manifested as xanthelismas, xanthomas. So, xanthelisma we know is a deposit of cholesterol around the eyelids or on the eyelids. You must have seen in some patients yellow spots on the eyelids are present. Xanthoma is on the extensor surfaces, Also, there is one more characteristic feature whose pathology is not fully understood, and that is a pure sensory peripheral neuropathy. A highly characteristic finding. Pathology is not known. Pathology is not fully understood. Pure sensory peripheral neuropathy. Pathology could be like maybe bile induced nerve damage can be there. So, this is the second cirrhosis where peripheral neuropathy is seen. First cause was alcoholic cirrhosis, and second is primary biliary cirrhosis. So, if you remember all these points, diagnosis is made from the clinical history, from the clinical feature itself. So, if we come to the investigations of primary biliary cirrhosis, because this is autoimmune phenomena, it is antibody, and this antibody, because in any autoimmune disorder there will be some sort of antibody. So, antibody is anti-mitochondrial. antibody, anti-mitochondrial antibody. Then the markers, if we'll see enzymes, and this is also a question which has come, enzymes which will be elevated are obstructive enzymes. Will be increased rather than SGOT, SGPT, which are elevated because of mainly hepatocellular involvement. Here bile duct is obstructed, so these enzymes will be elevated, and examples are ALP, gamma GT, and 5' nucleotidase. 5' nucleotidase, they will be elevated characteristically. Now, third investigation, let's try to define the specific feature on liver biopsy, because we are doing liver biopsy in each chronic hepatitis. So second is obstructive enzymes will be positive because of bile obstruction, obstructive enzymes. And three obstructive enzymes we have ALP, which is alkaline phosphatase, then gamma GT, third is 5' nucleotidase, 5' nucleotidase. Now coming to the third, so we'll try to define biopsy in each chronic condition. Here liver biopsy is investigation of choice to diagnose primary biliary cirrhosis. Again MCQ. Investigation of choice for primary biliary cirrhosis is biopsy. It is not ultrasound, it is not cholangiography, it is biopsy. And what does biopsy will show us? Biopsy will show a non-suppurative intrahepatic, non-suppurative intrahepatic bile ductule fibrosis. Non-suppurative intrahepatic bile ductule fibrosis coming in the biopsy, no other diagnosis, it will be primary biliary cirrhosis. Primary biliary cirrhosis. Now, treatment. Treatment is this is the only cirrhosis which respond to medical treatment. So this is the important feature of this. What happens because of bile obstruction? Bile is toxic to the liver. And that induces injury, that induces inflammation. So if we'll make that bile non-toxic, so that will help. So how to make the bile non-toxic? We give urso deoxy cholic acid. It solubilize the bile, making it non-toxic. And this prevent the progression of cirrhosis. This prevent the or stop the progression of cirrhosis. So only drug modifying the natural course of cirrhosis is ursodeoxycholic, and that too only in primary biliary cirrhosis. Then we can try, because it is an autoimmune process, so we can try methotrexate. So methotrexate has some role, but absolutely no role of steroids. Though it is autoimmune process, but fibrosis has already occurred, so there is no role of steroid at all, and this will solve your one MCQ, that no role of steroid in cases of primary biliary cirrhosis. And when primary biliary cirrhosis become advanced, or we can say decompensated. In that case, we go for a liver transplant. Liver transplant. So, what is the status of disease after liver transplant in primary biliary cirrhosis? So, this is one of the disease which has now shown to recur, because now we have more experience with liver transplant. Initially, say within 10 years of liver transplant, there was no recurrence, but after 15 years, few cases have recurred. So, what status will write? That recurrence is seen, but it is rare. Recurrence is rare, so few cases have occurred, but not so common as autoimmune hepatitis. Autoimmune hepatitis. Now, coming to the fifth cause of chronic hepatitis, and again, this was the question in May aims, and that answer was non-alcoholic steatohepatitis, or short form NASH, NASH, non-alcoholic steatohepatitis. So remember, this is of high importance, especially in India. In India, non-alcoholic steatohepatitis. So let's understand first its pathology. When will we say that it is a non-alcoholic steatohepatitis? So first we have to define the dose of alcohol. The dose of alcohol which is not responsible for fatty liver, not responsible for hepatitis is. So dose of alcohol is 0 to 20 grams per day. So it is not कि patient should be a totally teetotaler, that patient is not taking alcohol. Good, but if patient is taking up to 20 gram of alcohol daily, that amount of alcohol will not be responsible for liver injury. Liver injury. So up till 20 is safe for a liver. Is safe for liver. So then what is the agent which is causing the damage? So the agent which is causing the damage, or we can say the etiology, is this term known as insulin resistance. This is the term, or this is the etiology which is mainly responsible for non-alcoholic steatohepatitis. Non-alcoholic steatohepatitis, insulin resistance. So how does insulin resistance come? We have broadly two groups, and these two groups are contrasting groups responsible for insulin resistance. First group is obesity, that is more fat in the body, more will be insulin resistance. So adipocytes, more adipocytes, they decreases the action of insulin. So one extreme is obesity, along with that type 2 diabetes, where the one of the pathogenesis is insulin resistance, Then the second group is a contrasting group. Sorry, it is starvation. So how does starvation induces insulin resistance? Remember, it is through adaptation. Look, in starvation, individual is not getting food. It is not get. He is not getting carbohydrates. So, in order to prevent hypoglycemia, there is a adaptive response that insulin become ineffective, so that patient will not go into hypoglycemia. If insulin was effective, it will be able to decrease the glucose in the blood. So glucose should remain for a longer time. So this adaptation occur, leading to insulin resistance. Now, what does this insulin resistance cause? This insulin resistance through complex pathways, IR, insulin resistance, cause deposit of triglyceride in liver, in skeletal muscles. So there is a deposit of triglyceride, or we can say fat, in these organs, through a complex process of insulin resistance, So if we'll see the stages of non-alcoholic steatohepatitis, it is fatty liver, then hepatitis, then cirrhosis. This is the sequence of stages: fatty liver, hepatitis, cirrhosis. So let's understand the mechanism. So mechanism is always usually similar to the alcoholic fatty liver, that there is a triglyceride deposit leading to fatty liver. And this triglycerides, they undergo a step called as lipid peroxidation, and this leads to same oxidative injury, and hence hepatitis. Oxidative injury is much more than alcoholic hepatitis. Therefore, here is the role of antioxidants. Antioxidants help in non-alcoholic steatohepatitis, because this is more common mechanism, more strong mechanism for hepatitis. And of course, when there is a injury or inflammation going on for a long time, fibroblast will come in a chronic inflammatory stage, and these fibroblasts then lead to the cirrhosis phase. So almost similar steps for injury, like alcohol, but there are some differences. Differences are, if we look at the cirrhosis, the type of cirrhosis, it is macronodular. Macronodular cirrhosis is seen in contrast to alcoholic liver disease. Now there are no as such clinical features, unique clinical feature of non-alcoholic hepatitis. It will depend on the underlying cause. Now straight away coming to the investigations. And the most important non-invasive investigation that distinguish it from alcoholic hepatitis is the ratio SGOT upon SGPT ratio here is less than equal to 1. Again the question has come, कि ratio more than 2 is seen in all except. So answer is non-alcoholic steatohepatitis ratio is less than equal to 1. Then coming to the enzymes. Other enzymes which can be elevated are again obstructive enzymes. Elevation, and this is because of same fatty liver which is causing bile flow obstruction, Now let's try to define the liver biopsy findings. Liver biopsy. So also depend on fatty liver stage. It will show macrovesicular fatty liver. Same as that in cases of alcoholic fatty liver, macrovesicular. Then when we'll do a biopsy in a hepatitis phase, here again Mallory hyaline bodies are seen. Here also. And when we do biopsy in a cirrhosis phase, now here comes the difference. It will show a macronodular cirrhosis. Macronodular cirrhosis. In contrast to micronodular, which is seen in alcoholic liver disease. Now, treatment. So remember, the treatment consists of treatment of underlying cause. That is the only treatment for non-alcoholic steatohepatitis or non-alcoholic fatty liver. So let's do one by one. The underlying cause first was obesity. So the drug used in obesity, approved drug is orlistat. By inhibiting the lipase. Other drug which is used and approved is topiramate. And another agent lorcaserin is again a centrally acting, both are centrally acting anorexic drugs used for obesity. So indirectly, if there is a non-alcoholic fatty liver, drug used are these drugs. Drugs are for obesity. Now, for type 2 diabetes, especially that drug which decreases insulin resistance. So can you name the most efficacious insulin sensitizer, which is the best drug for insulin resistance in diabetes, which decreases insulin resistance? Best, we can say the best efficacious, most efficacious drug in diabetes mellitus, and that has been banned say 6-7 months, but now again has come. Not metformin. Metformin, yes, it is an insulin sensitizer, but less than that of, you will be surprised, pioglitazone has got more insulin sensitivity action than metformin. Yes, more insulin sensitizer. Now other drug, and that has been a research from AIMS, and that they have shown antioxidant, and only though we have many antioxidant like vitamin C, but the best effect was seen with vitamin E. So it is used for non-alcoholic steatohepatitis. Again, a potential question, especially for AIMS exams, that antioxidant, there is a role of there is a role of vitamin E. There is a role of vitamin E for non-alcoholic steatohepatitis. Then, what you will do for this condition, especially in India? What is the treatment for starvation? This you have already done. You have voted for Modi. Now starvation will go. You have already done your part. So these are the treatment options for non-alcoholic steatohepatitis. Coming to the fifth, or we can say sixth, and that is metabolic. यस अच्छे दिन आएंगे और अच्छी रात भी आएगी, डोंट वरी. अच्छा हाँ हाँ अच्छा अच्छा हाँ. So metabolic conditions, first is Wilson's disease. Is Wilson's disease. So let's see कि what is the pathology of Wilson disease, starting with the pathology. So there are many pathophysiologies occurring in different organs, but a common pathology is free copper. Free copper binding with apoceruloplasmin. Free copper binding with apoceruloplasmin, this step is defective. Free copper binding with the apoceruloplasmin. And what should be the product? Product should be ceruloplasmin. Product should have been ceruloplasmin, which is a bound copper. Which is a bound copper. So this will decrease. This will decrease. So this is a common pathology occurring systemically, and free copper is not able to bind with the apoceruloplasmin. So what will happen? The level of free copper will increase. So this free copper will increase, and that free copper will go into different body parts and will do have clinical features. So the clinical features of Wilson's are due to excess deposit of copper. Excess deposit of copper, and copper is toxic to the cells, it damages the cells. So this free copper will go to the organ liver, and in liver there is one more metabolic defect, and that is ATP 7B mutation, and that lead to decrease of copper excretory protein in the liver. So if copper excretory protein is reduced, there is increased copper which is coming, and it is also not able to excrete out from the liver. So liver is affected very early. very early in the course of a disease. So if we'll say the age when liver is affected, again MCQ, old MCQ which has been asked, is 15 to 19 years, is 15 to 19 years. And the liver is affected in three forms: chronic hepatitis, cirrhosis, and hepatocellular carcinoma. So in this way liver is affected. So it is the earliest organ to be affected, earliest organ to be affected in the age group of 15 to 19 years, 15 to 19 years. Now other organ affected will be CNS, will be CNS, and it depends on the site of the CNS ki what will be the clinical manifestation. So if site is basal ganglia, basal ganglia, Parkinson, it will be Parkinson. Then if site affected is frontal cortex, it shows neuro psychiatric abnormality, neuropsychiatric abnormalities. If cerebral cortex is involved, cerebral cortex is involved, then the patient will have seizures, will have seizures. If cerebellum is affected, of course ataxia. It do affect cranial nerves. So cranial nerve affected is 12th. It will show dysarthria. If cranial nerves 9th and 10th, it will have dysphagia, will have dysphagia. So CNS is involved in multiple ways, multiple sites are involved. So the important thing is ki again question ki which part is not involved in CNS, in Wilson's disease, in Wilson's disease. There are two parts which are not involved. One is a sensory system as a whole, sensory system is not involved. And second part which is not involved is the motor power. Remember, not motor system. Motor system is affected, but in motor system, motor strength, muscle strength is not affected, is not affected. So these are the two areas or two parts which are not affected in a case of Wilson's disease. And the age of CNS involvement in Wilson's disease, usually the age is 21 to 25 years. 21 to 25 years. So it is affected after liver involvement, after liver involvement. Now coming to the third organ which completes the triad of Wilson is the eyes. And the classical manifestation is copper deposit in the cornea, that is Kaiser, Fleischer, ring. KF rings, Kaiser-Fleischer rings in the cornea due to copper deposit. And second is sunflower cataract. Sunflower cataract. So what is the significance of age? Significance of age is the importance being which manifestation come first and followed by which manifestation. So if patient is presenting early, or what we can say, suppose we did a genetic studies of the genetic studies of these relatives, and we know ki which age group is this. Suppose the patient is diagnosed as the age group of say 10 years, so we are sure that liver will not be affected at that stage. And if patient is genetic studies diagnosed at the age of 30 years, that means liver has been affected already. So that will be the significance of age, ki when is the patient presenting and which organ system that we should focus on. And fourth, of course, is the RBCs. Fourth is the RBC. So RBC is copper damages RBC membrane. Copper damages RBC membrane, and that is responsible for hemolytic anemia. Hemolytic anemias. Now coming to the investigations. So first is that what we'll do, we'll do the screening test, or we can say the non-invasive test, which will suggest about Wilson's disease. And remember, for the past 1 or 2 years, questions are coming just on the investigations of Wilson's disease. So first is serum ceruloplasmin. So serum ceruloplasmin will be of course low, levels are decreased. And if we do a serum free copper, that will be increased. And when we will do a serum total copper, that will also be low. So why does it low? Because we know that serum total copper is a combination of free copper plus bound copper, and the major fraction is a bound fraction. So if that is decreasing, total will decrease, while free copper is a minor fraction and minor fraction is increasing. So and that increase free copper usually does not stay for a long time in the blood. It goes to get deposited in the various organs. So the decrease is not to that percentage as the decrease of bound copper. So bound copper is decreased much more than the increase of free copper. So the total copper decreases, and this is 2 times repeated in AIIMS exam. That is the serum total copper. So fourth is what will happen to urine free copper. Urinary free copper values. Remember, in kidneys there is no defect of excretion. So whatever the increased copper is coming to the kidney, it will be increased. And there was a question ki how does kidney be affected in cases of Wilson disease. So this copper is excreted through the glomeruli, and it damages the tubule, or it can cause dysfunction of the tubules where it is coming into maximum contact. So if a thing is filtered through the glomeruli, so the maximum contact after filtration will be the proximal tubule. So it causes proximal tubular dysfunction, and responsible for it is responsible for renal tubular acidosis type 2 which is due to proximal dysfunction. So suppose if question comes how kidneys are involved, it is through proximal tubular dysfunction, which is a renal tubular acidosis type 2. And if question comes about the confirmatory test. So confirmatory test is liver biopsy. And in liver biopsy, what we can see, so questions are Nazar criteria, that is for the treatment of the Wilson, that I'll let you know. Normal values of remember, it will be very difficult to remember the normal values of copper, but remember the values of liver biopsy copper status, because that will make a diagnosis. And diagnostic test for Wilson, remember the confirmatory test is the diagnostic test for Wilson disease. All other we can say are non-invasive, the screening test for Wilson's disease. So liver biopsy will show a copper level of more than 200 grams per gram of dry liver weight. So this makes a diagnosis of Wilson's. This will make a diagnosis of Wilson. Copper in the liver more than 200 microgram per gram of dry liver weight. Now diagnosis is made. Coming to the treatment. So treatment depend on the stage of or the organ involved. Stage as well as the organ involved. So the important organ involved is the liver. So for liver, if there is a chronic hepatitis phase, here we give zinc. And how does zinc help? Zinc decreases copper absorption from the GIT. So both are positively charged, so they compete with each other. So zinc will decrease the copper absorption from the GIT, as well as zinc increases the expression of copper excretory protein. So this copper will now be started excreting from the liver. So both ways it is helping. Decreasing the absorption as well as increasing the expression of that protein, relieving the liver from the copper, but useful in the chronic hepatitis phase. Now if a patient has gone into cirrhosis, especially severe or advanced decompensated phase, severe or advanced decompensated phase. So the only option left with us will be a liver transplant. Will be a liver transplant. So this liver transplant advantage is the disease does not recur after liver transplant. So this is one of the condition, metabolic condition, which does not recur after liver transplant. After liver transplant. Now, if CNS is involved, if CNS is involved, so we give zinc plus we give tetra thiomolybdate. And tetrathiomolybdate is also is a type of copper chelating agent. Copper chelating agent. Remember what these drug are doing in the CNS, that they are arresting the disease. They will not what we can say reverse the disease completely, but they are arresting the disease progression. Zinc and tetrathiomolybdate. So very important is to screen for the relatives also. So if some relative has been diagnosed, so dose of zinc, frankly speaking, I don't know what is the dose of this thing, because these numerical values are very difficult to remember. So therefore I'll let you know tomorrow what is the zinc dose that we give in cases of Wilson's disease. So fourth is when the relative is diagnosed with in asymptomatic phase with Wilson's disease. Genetic profile is Wilson's disease. So to prevent the deposit of copper and to prevent the irreversible disease in asymptomatic phase, we give zinc. In asymptomatic phase, we give zinc. Zinc is so safe that it has no side effect as such, and that can be given in pregnancy also, and it can be given in pediatric population also. In pediatric population. So to prevent some sort of irreversible damage, we give zinc even in asymptomatic stage, and that there is no role of observation. There is no role of observation in these patients. So this was the Wilson disease, and the most important thing in the treatment you remember is the recurrence after liver transplant. Is recurrence after liver transplantation. Now coming the second metabolic disease, and second metabolic disease is alpha 1 antitrypsin deficiency. So D-penicillamine, remember before the use of zinc, D-penicillamine was given because it is a metal chelating agent, but D-penicillamine has got side effect. It causes autoimmune reactions. It can cause nephrotic syndrome very frequently. So we now go for a safest option. So now the drug of choice is zinc and not penicillamine. Penicillamine was earlier used for Wilson's disease. So next metabolic defect is alpha 1 antitrypsin deficiency. So tryptophan. Tryptophan is also copper chelator, and the role is, before in cirrhosis phase, before liver transplant is done, what we'll do, we'll put the patient on zinc plus tryptophan for some time till the liver transplant is there. So tryptophan is again a copper chelating agent, and that is used in cases of cirrhosis phase of Wilson, not in chronic hepatitis, in the cirrhosis phase, in the cirrhosis phase. So the class will be over by, I think the time was 9 o'clock, or this topic is finished, alpha 1 antitrypsin deficiency. So whichever is earlier, we'll finish the class that time. So alpha 1 antitrypsin deficiency, if we'll see the pathology, so due to this deficiency there is increase in elastase. There is increase in elastase enzyme because normally antitrypsin is inhibiting the elastase, and if that is deficient, elastase activity will increase, and that will work on two sites commonly. One is lung and second is liver. So in the lungs it can destroy the parenchyma, or it can destroy the airways in the lungs. So parenchyma, it causes emphysema, and typically it is a pan-acinar emphysema, while airway are affected, and that is bronchiectasis. In the liver, sequence is same, chronic hepatitis, cirrhosis, hepatocellular carcinoma. So these are the three stages in liver, and clinical feature will be simultaneous involvement of lungs and liver with this emphysema goes in favor of alpha antitrypsin deficiency. Now coming to the investigations. So the test that if we are suspecting a case of alpha antitrypsin deficiency, so we go for a serum alpha antitrypsin levels, and that will be low. And if there is respiratory symptoms more than the liver symptoms like jaundice, so first we go to diagnose the lung disease, and the investigation of choice for emphysema, to diagnose emphysema and bronchiectasis, is a single investigation, and that is HRCT chest, when there is clinically lungs are involved. And for liver, let's try to see the biopsy, whether there will be any specific biopsy changes or not. Yes, there are highly specific biopsy changes, and because of elastase, the tissue or the cells in the liver undergo changes, and that is manifested in the form of a PAS positive diastase resistant globules in the liver. So this is important, PAS positive diastase resistant material or the globules in the liver. So this is highly specific for alpha 1 antitrypsin deficiency. Now the treatment. Treatment is if we give recombinant alpha 1 antitrypsin, because this is deficient in the blood. So if we supply this recombinant alpha antitrypsin, this should help, but clinical trials have shown that it is effective only for emphysema. So emphysema will stop. But not bronchiectasis, not liver disease. Reason is not known ki why it is affecting the lungs. It is useful only in the lungs. And that is the only treatment for emphysema which alters the natural course of emphysema, alters the natural course. So this is of highly importance that if we are suspecting a case of alpha 1 antitrypsin in emphysema patients, then we should do the test alpha 1 antitrypsin and then go for recombinant alpha antitrypsin therapy that will stop and modify the natural course of disease. While unfortunately we do not have any specific treatment for chronic hepatitis, therefore unethically we wait till cirrhosis. We wait till cirrhosis because we do not have any treatment. So when the patient reached a cirrhosis phase, we go for liver transplant. And the importance is after liver transplant, it does not recur. It does not recur. Though it is a metabolic disease, but it does not recur after liver transplant. So there are two diseases, Wilson's and alpha 1 antitrypsin, which does not recur after liver transplantation. After liver transplantation. So this ends the alpha 1 antitrypsin. So what we'll do, tomorrow we will do the third metabolic disease, which is hemochromatosis. Then we'll do the complications of cirrhosis and then intestinal part, then finish that GIT part. And tomorrow also we'll try to cover up the respiratory system also. So before leaving and dispersing, just a last question, and question is which disease causes increased liver copper plus KF rings? Which disease cause this? So if we are not reading the option, answer is very simple, but when the options are given, question becomes slightly difficult. And options are primary biliary cirrhosis, So for bronchiectasis, again a supportive treatment like physiotherapy, improve the drainage of secretions, mucolytic agents. So yes, answer is Wilson's, but Wilson is not given in the choice. Choices are primary biliary cirrhosis, autoimmune cholangitis, primary sclerosing cholangitis, all the above. So now what is your answer? Because Wilson is not given. Wilson is not given here. Yes, the majority of people, they are saying that it is all the above. Answer is true. It is all the above, because remember, increased liver copper with KF rings increased liver copper with KF rings is, besides Wilson, is also seen in any condition which is causing a chronic cholestatic liver disease. Because copper is excreted through liver if there is a chronic cholestasis. Chronic means over months to years. It is not acute cholestasis. It will be months to years that leads to deposit of copper in the liver, and that liver copper can affect the cornea also, KF rings. So These are the examples of chronic cholestatic conditions. The answer is all the above. Answer is all the above. And this is a question which comes in the DNB exam. DNB exam. So with this, so I think today we'll stop here, and then we'll resume with the next metabolic disorder, which will be hemochromatosis.